Good morning, everyone. Welcome to the December meeting of the Universal Health Plan Governance Board. I'm gonna give a minute for Isabel to let folks into the room and then we'll get started.
I'm all set.
Okay, great. Great. Welcome, everybody. Let's get started with a roll call.
Helen Belanca.
Here.
Shenwei Chi is absent. Amy Fellows. Here. Michelle Glass.
Here.
Bruce Goldberg is on leave. Judy Richardson.
Here.
Cheryl Ramirez.
Here.
Mary Lou Henrich.
Here.
Mike Leahy.
Here.
Thank you. That's everyone.
Great. Excellent. So another packed meeting today. Let's do a quick agenda review. We're gonna hear from our executive director with some updates. We're gonna have a board discussion about our transition and timeline. We have some decisions to make there and some input. We'll be doing a little bit of level setting around our principles and some tax information that we had early on in the board's work that I think will inform some of the decisions that we have at this meeting and at the next few subsequent meetings. So we thought we would just do a little bit of ground setting around that. And then we have pretty robust committee updates today, so let's get to it. I'm going to start with a synopsis of our written public comment. As always, thank you so much to the members of the public who took the time to write in. Ruth Zuniga, Eileen Gilson, Kayla Boyd, and Julie Osborne expressed general support for the Universal Health Plan. Heather, with no last name submitted, is a cancer patient who's had to coordinate her cancer medication shipments from a company in Chicago due to network restrictions on pharmacies and pharmacy benefit managers. She requests that the UHP cover all medications, give patients a choice of pharmacy, and ensure that Oregon pharmacies carry enough of the specialty drugs to meet demand. Patrick Odell commented on the effect uninsured patients have on hospitals and expressed support for the UHP. Lou Sininger advocated for everyone to pay something for the UHP, even those below the federal poverty level. He advocated for not paying more for dependents and advocated against brick and mortar regional entities and against value-based care. Erin Krause advocated for coverage of dental implants for functional issues, not just cosmetic. Dr. Stephen Kemble submitted a really great multi-page testimony with a detailed proposal for paying for primary care and hospitals. I encourage all board members and committee members to read that. Linda Krieger wrote to ask that the Plan Design and Expenditures Committee consider Dr. Stephen Kemble's proposal for primary care payment. We did meet with Dr. Kemble this past month. Mimi and I, we had a great long conversation with him, and we plan to continue to be in touch. He's a really great resource, so we appreciate that connection. Anna Tom wrote in to point out that the proposals from Finance and Revenue are referring to a progressive tax when actually the only thing they've proposed so far is a proportional or flat tax where everyone pays the same percentage of their income. She points out that a progressive tax would take a larger percentage of income from higher earners and that Finance and Revenue's guiding principles call for a progressive tax. Colin Stackhouse wrote to express concern about lack of public engagement, encouraging us to do more between now and September before the report is due. And Michael Huntington wrote in to propose that we launch a $30,000 public relations campaign to increase awareness of the board's work and encourage participation, including digital ads, videos, surveys, interactive web content, and listening sessions. And that's all for that. Next on our agenda, we need to approve the meeting minutes from the November meeting. Is there a motion to approve the minutes?
I had a couple slight things. Page 3, it's Representative Nose, not Senator. We could promote him. And there was something. I guess that was my only specific things. I had a few questions about things, but but I think they accurately were reflected, so just
Great.
Senator Noakes becoming representative.
Is there a motion to approve the minutes with that edit?
So moved.
Okay, Mike, is there a second?
Second.
Amy seconds. Any other discussion? Go ahead.
Is a postscript to the minutes. I made some brief remarks about 10 years from now, if we were successful, what would that look like? And I've gotten over 50 comments. And I just clarified with Isabel, I'll get as many of those comments into the public record, but one of the issues, people just sent them to me as private citizens. I think I ethically need to check and see if those comments were meant just for me or for the public. I will do that process, and so there'll be some additional public feedback in conjunction with the last.
But they wouldn't be part of the meeting minutes from the last meeting.
I'm gonna leave it up to you and Isabel.
So the
I'm
meeting
really
minutes-
saying that there's some additional thoughts from people.
Yeah, that's great. And we would love to have those as part of, in general, our records, but what we're approving right now is the minutes from our meeting. So because those comments weren't included as part of our meeting, I don't think they should be part of the minutes, but we should figure out a way to incorporate them somehow into public feedback.
Right.
So any other discussion about meeting minutes? Okay, let's do a roll call vote.
Helen Belanca,
Yes.
Chen Wei Chi is absent, Amy Fellows.
Yes.
Michelle Glass,
Yes.
Bruce Goldberg is on leave, Judy Richardson,
Yes.
Cheryl Ramirez. Mary Lou Henrich,
Yes.
Mike Leahy.
Yes.
That's everyone.
Thank you. Is there any public comment on voting topics today?
Yes, there is. Yes,
How many people?
at least 3. I need to see if there's been any new signups from the people attending today. Thank you. Thank you. Yes, yes, so we have 4 people for voting public comment today.
Great. I'll let you announce them, Isabel, and I'll ask everyone to keep their comments to 2 minutes, please.
So the first person today is Lou Senator online. You should be able to unmute and share your comment now.
And for this part of the public comment, I'll ask the speakers to please start by saying which agenda item that we'll be voting on you're speaking in reference to, just to make sure that we're all on the same page. Go ahead, Lou. Lou, are you there? Let's go back to Lou.
Yes, I'm here.
Oh, okay.
I don't know, I can't quite hear everybody there very well, and I have my computer turned up, so. Anyway, Lou Senator here, I want to speak on the issue of regions. I think it's very important that we come out with a good understanding of regions that will allow people and the public to have good ownership and feedback into the system. However, I'm really confused about the regions that they're as outlined. Remember, this is going to be a centralized database, and that centralized database will see every action, every use, every claim that comes in. I'm confused about the one that includes Lane County, Douglas, and Coos Bay. Douglas has 1 hospital, Lane County has 2, Coos Bay has 1 hospital, is publicly owned. and it's going broke. They have put it up for sale. How does that region make any sense? They're completely different. So I think it's important that we have feedback centered around the public and that we create um, uh, meetings to public, very much like the CCO did when it first got started. It was very dynamic and helped in organizing their method. So thank you very much. Good luck in trying to figure all this stuff out.
Thanks, Lou. Judy's going to be addressing that in her presentation. We appreciate that. And who's next?
Next, we have Tom Sinsick.
I'd like to defer to Colin before I go. That's all right.
Is Colin signed up too?
Yes.
Okay, go ahead, Colin.
Yeah, that's a great idea.
Yeah,
Please
cool.
do.
Thank you. Yeah, just so people online can hear better. Hi, the topic that I wanna talk about that's related to something that we're gonna vote on is the Universal Health Plan timeline. I guess I'll talk about two things. One is the board and committee meeting procedures, and the other is the proposed transition timeline. Yeah, I do have a lot of concerns with like the amount of public engagement and the way that we're able to encourage people to come. Like, you know, as a nonprofit, Healthcare for All Oregon, a nonprofit focused on universal healthcare. You know, we got 3 people here, you know, to talk to you, and it's not enough. You know, we need to have, I think, better opportunities for public engagement, and I think that there is the possibility to be more flexible within like the regimented, maybe that's not the correct word, but the framework that is in a lot of ways inflexible. I think that I would really encourage you guys to be a little more creative and flexible with the kinds of meetings that can happen, and specifically like having meetings that are not at 9 a.m. on a Thursday, so more members of the public can attend. And I really think that there is a need for a dialogue, you know, people asking a question, and even if the answer is, well, there's 5 possible answers, or even if the answer is, well, we don't know, but these are the 3 things we're considering, I think that's going to be convincing of the patients in Oregon of what the crazy amount of work that you guys are trying to do. Like, it's more convincing if there's as many options for public engagement as possible. In the last 30 seconds, I want to talk about the magic wand that I want us all to be able to have, which is this timeline for the OHA opportunity, the ways that OHA perceives we can get those federal waivers, and how 2032 is the timeline that they've shared. And gosh, that's just so far. It's like not reasonable to be in a state of emergency with our healthcare system and to have this 6-year timeline as like our baseline. So thank you.
Thanks, Colin.
My name is Tom Sinsick. I'm president of Nurses and Friends for Single Payer, and this is a single payer movement for all of you who actually follow that. I'm here to follow up with Colin, the issue of community engagement. The core of this work is community engagement, which should include more a community dialogue. And as there is this system where you listen, this is standards with the state, but there's not a dialogue back and forth. If I ask you a question, I'd like to know something maybe in that timeline. So we could, or if you need further understanding about what I'm saying, somebody on the committee could ask about that. So it's the dialogue piece. And then in addition, the time allotted, a time frame, when the meetings are, more flexibility, maybe think about changing those around. I think that's part of the proposal here today. The location, at least something. This is great. I mean, this is, in fact, it's online. But just even if you had a presence in another community or two, it'd be great. And the time allotted for these discussions, there's 4 people today, that's 8 minutes. This is 5 minutes on the agenda. So it looks like the public is being squeezed into these meetings. And so I guess that's all I want to say. This is about the dialogue and not about just listening or reading. You've read everything. We appreciate that you've read everything. We appreciate the hard work, but you've got to include some dialogue in this system, and it's got to be more open. Thank you very much. for your time.
Thanks, Tom.
And next is Mike. Mike Huntington.
No, I could go down. Well, I'm Michael Huntington, a retired radiation oncologist from Corvallis. I speak on behalf of Mid-Valley Healthcare Advocates. Most Oregonians struggle with high healthcare costs, but do not know that a universal health plan governance board exists, or that it needs their input. A focused $30,000 public relations campaign can quickly raise awareness of the board and convert that awareness into concrete public participation. The campaign strategic goals of this would be to make basic awareness of the board widespread, who it is, why it matters now, and that it needs broad public guidance on designing and funding universal healthcare. Then turn that awareness into signups, testimony, survey responses, and applications for advisory roles. Messaging should lead with shared concern and readiness for change, referencing polling that shows large majorities of Oregonians see healthcare costs as a serious problem and support government-led solutions. That concern then is directly linked to the board. This is where the decisions on a new universal health plan begin, and public voices are needed now. As a separate note, last summer, you approved a straw proposal for a capitated value-based primary care provision. I and other people have expressed concerns in testimony here about the administrative overhead of time and money associated with value-based payments and their propensity for being gamed. I have a feeling that because the proposal was a straw proposal, it did not receive the in-depth discussion that it deserves. Please have that discussion with particular attention to testimony from Stephen Campbell, MD, a board member of the Hawaii Health Authority and assistant professor of medicine at the University of Hawaii. Thank you.
Thank you. As a quick reminder, we hold this space at the beginning of our meetings just for testimony on stuff we'll be voting on. So, but we appreciate everyone's comments. Okay, great.
I didn't sign up to speak for minutes.
Okay. Okay, great. Anyone else? Okay, great. Let's move on. I'm going to hand it over to Mimi for our executive director report.
All right, thank you. Good morning, everyone. This is Mimi McDonald, Executive Director for the Universal Health Plan Governance Board. And if you'll go to the next slide. All right, so we're going to start off with providing follow-up on some questions that came up during our last board meeting. These were three of the highlights. I'm going to speak to the first two, and then our Vice Chair, Dr. Judy Richardson, is actually going to provide a brief presentation on the third point. So the questions came up about small businesses in Oregon, about how many provide health insurance and what perhaps the payroll tax implications will be in terms of implementing an employer payroll tax. And then also kind of adjacent to that is number of self-employed in Oregon and what proportion fall above and below the $500,000 payroll cap. So next slide. All right, sorry for the tiny data and the tiny thing, but what some of these questions we're not able to address directly because the data is not always sorted out in that way. But what I can tell you is this is from Q2 data from 2025. Approximately 2 million people in Oregon are employed, about 1.7 million in the private sector, about 300,000 in the public sector. Now, as most people know, a large number of Oregonians and the number of firms that are considered small businesses or less than 50 employees, there are way more small firms than there are large firms. So 39% of employees work for firms with 0 to 49 employees. So that's about 670 to 700,000 people work for those small businesses. And again, this is not it gets a little bit tricky. And the way that they describe it in the literature is that about 400,000 people have 0 employees. In other words, they're self-owned businesses. So the percentage with the total annual payroll of those small businesses, $500,000 or more, is actually relatively small, likely in the single digits. So not surprisingly, some of the majority of these are, 5 or fewer employees. So most of the small businesses, self-employed persons will not incur an employer payroll tax. And the corollary to that is, I think people are aware with the Affordable Care Act, businesses that have 50 or more people that are employed full-time are required to provide some type of health insurance. And that can be through, they can either be self-insured or they can buy insurance through a health plan. So I guess what kind of, like I said, there's not necessarily a specific direct answer, but this is the data that we have that's available. And I think as we get further into the revenue plan, we'll have more specifics about which group is contributing what to the total revenue plan. So, see if there's any questions. I had a bunch more slides, but in the interest of time, I thought we better condense this. All right, going on to the next slide, and I'll turn it over to Vice Chair Richardson.
Great, thanks, Mimi. This was in response to Mary Lou's question last month about clinician employment data and where physicians work in this state. And coincidentally, we just had this discussion in one of my classes, so I offered to provide the data. Go ahead, next slide. So, yep, the note about terms. So just for a little bit of level setting for folks who maybe aren't like in the heat of all these conversations, when we say provider, sometimes that can refer to an insurance provider, a hospital, an integrated delivery system, which is a whole connected network of hospitals, clinicians, and insurance. When we talk about people who do medicine in the office, we generally refer to them as clinicians. And so I just call that out so that we don't conflate those two ideas. And then I think it's important to, I always ask for clarity when we're talking in this sphere, like, which do you mean? Do you mean provider group, or do you mean like a hospital or insurance, or do you need a person who goes in and listens to people and writes prescriptions? So, and in Oregon, that includes doctors, DOs, NDs, nurse practitioners, clinicians, they can practice independently, PAs, physician associates, who were called physician assistants formerly. And Oregon can also include other practitioners like naturopathic providers. However, the data I pulled does not include naturopathic providers. Next slide. So if we look at Oregon, there are 12,000 actively practicing physicians in Oregon with 19,000 licensed. So that's primary care there. Physician associates, 2,191 actively practicing, with more who are licensed, and nurse practitioners about 7,600. So if you think about if all those nurse practitioners were practicing primary care and you lump them with the 12,000, we'll say that's okay, maybe 19,000 licensed practitioners. There's 4.7 million people in the state of Oregon. That like pencils out to 375 to 1. So you may ask, why do we have an access problem? Well, the reason is those clinicians may or may not be practicing full-time. So generally I spitball a full panel is like 1,200 patients per physician. So that's where that idea comes. It's really clear that these are not full-time, all licensed practicing full-time. There's definitely a mix. The next slide. So nationally, I think this gets to Mary Lou's question. Nationally, 77 to 78% of physicians are employed by hospitals. We've known that long gone are the days of the independent doc hanging a shingle and just opening up shop. That is really not existent or very, very rare these days. In Oregon, out of 12,000 actively practicing, 65 to 75% of all Oregon physicians are now health system or corporate employed, rather than owning their own practice. And so that would include if someone is an employee of an IPA or an independent practitioner association, a hospital, they work for Pfizer, they work for United Health, they work for OHSU like I do, however that is, they work for somebody else and draw a paycheck. And so for primary care, it tracks 65% are employed in a clinic, 20% in a hospital, 12% in private practice, and 5% other, and that might be concierge care or the carceral system, they might work in a jail. That's where that 5% is. Concierge is where it's kind of like a membership. So generally we see those in more affluent areas where people can buy into their personal law. Next. I didn't have data to break down practice and employment settings for specialty care. Most of this data comes from the Oregon practice database. For nurse practitioners, there's 7,700 actively practicing, and you see the distribution there. So thank heavens we have them. Okay, the next one. PAs, physician assistants or associates, however they like to be called. There's 12,191 of them actively practicing. Sorry. I wish there were 12,000. There's 2,191 of them. And half of those are employed in a group or public clinic setting, a third in a hospital, and then private practice, 13%. And remember, they practice alongside nurse practitioners and physicians. Hey, that's it. Did that answer your question?
It does, and
Cool.
of course, it raises one more here, back on your goal for all practicing NPs, thank you, Judy, this is really helpful. I'm just confused on the distinction between office / clinic and primary care. Are those, so the office / clinic could be an NP that's at a surgeon's office?
Yeah, absolutely.
And
Orthopedics,
it doesn't-
surgeons, wound
it doesn't-
care, yeah.
Okay, it doesn't say specifically, the primary, because the
Correct.
primary care, I mean, that actually kind of saddens me,
Mm-hmm.
having been involved early on in the nurse practitioner movement. Our idea was really to have them in primary care settings, and using their skills that they brought from being nurses to the additional ones that they got in the nurse practitioner programs. But in our family, we actually have a nurse practitioner who is a very specialized bone marrow transplant, something, I know, which is you. And I'm kind of going, I've seen that a lot where they're in a specialty clinic assisting some kind of high level something or other. So anyway, that just kind of, but there could be, I guess, in some of the office clinic. So primary care also maybe.
Yeah, just not declared as primary care. They're in some multi-specialty group practice and they're
Yeah.
doing primary care. At a future board meeting, when we have more time, I'd love to talk about my next favorite topic, which is relative compensation rates in those various settings. So
Yes.
we can look at misalignment of provider payment and clinician payment.
Would love to see that. Thank
Not
you.
today.
Thank you very much. This really
You're
helps.
welcome. Thank you, Chair.
Great, Mimi, I think it's back to you for budget. Yeah, next slide. All right, just very briefly, I wanted to just update our budget. So this is as of October, the actuals, things are still looking good, if you notice. So in terms of, this is our biennial budget, so things still looking, we're approximately 169,000 in the black at this point. So we're doing well and staying within our budget. Next month, I'll provide another update on where we are with our consultants. We didn't have any additional data at the time of this one. So next slide, please. All right, and then we move this up to the executive director report, just talking about the board outreach that our board members have done. So Amy and Mary Lou both had outreach opportunities. I don't know if you want to, Amy, we'll turn to you, see if you just speak a moment about that.
I was asked to do a presentation for one of our regional health equity coalitions that is for Lane and Douglas counties. It's called Rise of the Umpqua Willamette Valleys. So I just kind of did this is the universal health plan. This is how you can get engaged. And from that engagement, now I was asked to present to the, I'm not really sure the makeup anymore, but it's the CAC, the Community Advisory Committee that used to be for both Trillium and.
Oh, so for Lane County, so that's
Lane
gonna be,
County.
yeah.
Yeah, the whole source, I'm not sure the makeup anymore, but yes, so that's happening in January.
Great, thank you. And Mary Lou.
Mine was a Zoom with Rebecca Schoen, Dr. Rebecca Schoen's health policy class, and she had actually some undergraduate lower, she mixed some people, they invited a few other people from her other classes, but it was basically their class on health policy. And I just used the slides, thank you, and then answered questions, and their questions were pretty basic. And they were very engaged. And it was, I think, their last class before the holiday break, so there was a little bit of, thank you. Can we get out of here now? So anyway, it was good, and Rebecca did a nice job of clarifying every once in a while. If I would say a term that she thought, maybe they wouldn't understand, she'd say, let me explain that, blah, blah, blah. So anyway, that was it. And I'd say there were probably 30 or so students.
Are they undergrads or graduates?
It was a mix because she kind of had two classes, so that it was aimed at the grads, but she allowed
The
the
undergrad.
undergrads to come in too, so it was a little bit mixed.
All right, and just to remind our board members, if you are going to have an engagement, please send it along to me, let me know, and we will certainly share all of the resources that we have in our updated slide deck, which has been so carefully curated by our Community Engagement and Communications Committee. So next slide, please.
Can I ask one question on the budget page?
Sure.
When you said that, I'm assuming that the contracts for our consultants is in that 781,000.
That's correct.
Okay, great, thank you.
All right, and so on to the next slide. Now, this is not meant for people to, I'm not gonna go into detail about everything that's happening. What I did want is for the board to have a sense of what is coming up in the next 6 months. And so I have it arranged by topic. So these are things that are going to be brought up at the board. Some of them will be voting topics, some of them will be more informational. What I'm trying to do is make sure that that there is things are happening relatively spaced over time, so we don't have a massive time crunch. And so I hope you will give me the grace to understand that some of these may change, and depending upon when consultants finish up their work. And I just also want to call attention again to that big sort of vast space in May and June. And so there's just so much of work that's going to be happening there, and really fine tuning what happens in the final report. The other thing I wanted to point out, and I'm sure that Amy and Michelle are going to talk about this later, is at the very top line is about engagement, and that has to do with the very specific targeted engagement meetings that Diana Bianco is heading up. And so just to note that sort of when that's happening and when the reports will be coming back to the board. So there's another slide after this one. Yep, I couldn't fit it all on one slide. So I just wanted to know that. And then I have, oh, I'm sorry. Yes. Thank you, Denise. Thanks for reminding me. I was speaking a little too quickly, which happens. So I appreciate that. The next point I wanted to make, I don't have a slide for this, but to let people know, we definitely have gotten feedback that as we've moved along and more things are being submitted and approved to the board, our website is getting a little messy and a little hard to find things. And we absolutely understand that. We are fortunate. We work with our DCBS partners, and I have Isabel, who is heading up this. So our website is, as they say, under construction. Most of the work is going to happen in January. So we are taking in people's comments. We are also getting input from Patty Wentz and our CECC committee to further make it more accessible. So I want people to understand definitely that their input is being heard, and we are working on it. We had hoped to get work done during December, but it's really more likely to happen in January. So thanks for your patience. Yes.
When you're doing that, I'm sure, nothing is ever sure, but I would hope that you're going to have a way so that like all the straw proposals
Yes.
could be somewhere we could find easily, rather than
Yes.
having to go. to
Yes,
each
you've mentioned
committee.
that. Yes.
Great,
Yes.
thank you.
Yes, and if people have suggestions, please send them in, email them in. Absolutely. We want to make it as searchable, as accessible as possible. And I think that might be it for me. Next slide.
Thanks, Mimi. Okay, so this topic, we're gonna get launched just to give people some context. At our last meeting, we had a little bit of discussion about the timeline of the board's work and how we would get from where we are now in our health system to a universal health plan, and trying to think that through. We proposed changing some of the dates for when the universal health plan would be implemented, and there was some discussion around that and some disagreement about a sort of a target date for implementation. And so we thought we would have a little bit of discussion to clarify where the staff and Judy and I have been thinking about that timeline. And somebody recommended that we start by looking at what other countries have done when they've transitioned to universal health plan, and then trying to put it in our context here in Oregon. So that's what we're going to do here for the next few minutes. I'm going to turn it over to Lee to get us started.
All right, thank you. Let's dive right in here. So I took a look at other countries and other places around the world that have gone from fragmented healthcare to a single payer universal healthcare system. and tried to assess what are the various steps they went through, how long did everything take, and what are kind of the key phases that we could expect if we're implementing universal healthcare here in the state of Oregon. And this really broke down to these 7 steps, and they are listed obviously in numerical order. To some extent, they follow this order, but just be aware every process is different. So there can be some flexibility within here. So let's dive right in. So I broke these down, these 7 steps, into 3 phases, really. The first one being what I would term agenda setting and design phase. This is far and away the longest phase. This can be anywhere from 10 years to 25 years. So we're talking quite a while. And this is really that little seed growing into a small plant. So we're talking about, there's a lot of germination, there's a lot of thought here. We always start with a problem narrative, though. And this is that kind of political movement of what is the problem? Our healthcare system is broken, and then creating a narrative around that. So famously in the UK, there was this saying of cradle to grave security. That's really the phrase that people were able to launch onto in order to build their national healthcare system. But it's really diagnosing what are the barriers, the inequity, finding what takes hold in the minds of folks to really make it rise to the level of we need reform. Second and kind of third, because these 2 can overlap, as you can see from this diagram. Again, these phases, these different steps really have a lot of overlap, a lot of interlocking aspects. But we get to that model choice and design. So really thinking about who is going to be the purchaser, whether it's the state or whether it's some other sort of entity that's maybe associated. And I'm using state as like nation in this term, looking at what is the financing mix going to be, what's that benefit package, and then really the nitty gritty of that financing, identifying those stable revenue sources, addressing what you're going to do with all those current fragmented expenditures. How do those get either absorbed or, kind of phased out? And then, of course, planning for cost containment. And all of this, to be clear, happens before there's any legislation. And that's part of why this phase takes so long. Also worth noting, coalition building, an important aspect of this entire phase. So it really spans across all of it, from developing the narrative, model choice and design, to that financing plan. And as all of these kind of come to a head, the end of this phase is really defined by having a flagship law passed and put into place. Next slide, please. So phase 2, this is what I would term the building phase, or you can think of it as the implementation phase. This is what happens between when the law passes and when you have that universal health care. And there's 2 key steps here. The first is integration. So this is figuring out, taking all of that fragmented, all those fragmented pieces and bringing them into a single system. So there's a lot of transitional measures that happen, usually for providers, to help make sure that they remain financially solvent during this time. There's consolidating private market public programs. There's thinking about benefits and how do you kind of bring benefits all to a similar level. There's handling any sort of legacy issues that may be out there, such as thinking about organized labor, for instance. There could be multi-year agreements. You need to figure out how you're going to kind of phase those down and move into the new system. And then the second big step here is that administrative infrastructure. So standing up your purchasing organization, building out your claim systems, deciding what those are, your IT, and figuring out how that's all going to work, including down to those ID cards. And at the end of this, you reach that launch point. You reach that go live date. Next slide. And then finally, I guess I called this one implementation phase. Excuse me. So this then, our implementation phase, this is where it has gone live, but we could still be in a transitional period. And the goal here is to get to what's called stable coverage. So we know that there's going to be some adjustments, some hiccups. We all know that when the ACA went live, there were definitely some hiccups with those exchanges, but I think we can all agree that within a few years, that was a pretty stable process. And that's what we're talking about here, where we've gone through all of that. So there's a whole sequencing issue. And again, this continues to be part of the transition. There's a launch, but maybe it's not launching everything all at once. Maybe it's launching in parts over a year, over 2 years. And this is really a choice that can be made. In the UK, they did what they term a big bang approach where it was full benefits for everyone day one. In Canada, this was much more incremental, and that's in part because provinces were encouraged to adopt these. They really got to set their own timelines. They got to do it in a way that was comfortable to each of them. Taiwan was a little closer to the UK. It's actually somewhere a bit in between, long planning, a short rollout, but they did take some time to integrate public programs fully in as well. And then there is, of course, ongoing reform. No system is perfect. This system is not going to be perfect no matter how much effort we put in, and the world is going to continue to change in ways that will require the system to change. So just acknowledging that this is really an ongoing thing, but at the end of it, we do have more or less stable coverage, a system that works, that functions, that covers everyone, that is equitable. Slide. So for examples, I don't want to take up too much time. I did start with Medicare just because, you know, that is actually something that was done in the US here. So pretty telling. That design and coalition building, just to point it out, that was 20 years of talking of the issue coming up from law to launch. That was only a single year though. And stable coverage, just noting some of those things such as initially Medicare relied very heavily on private payers. To some extent, they still do. UK, Canada, Taiwan, you see a really similar kind of thing. The UK, I did put 4 years here, but actually there was definitely work happening before the Beveridge report was issued. But even in that case, you can see a longer amount of time in that design phase than from law to launch. Canada, you're talking 10 to 20 years-ish, and then 2 to 5 for implementation. Taiwan spent a solid 10 years really deeply looking at the issue. And man, they really set a record there. They implemented in 8 months. So you can see there's really this very long extended design phase. And then once all those decisions are made, it can happen pretty fast. Next slide. Now, Chair Blanca is going to talk a lot more about this, but I wanted to provide a bit of a diagram just to say where we are, because I think a lot of people are afraid that we're going to drop legislation tomorrow. And just to be clear, we're in this long design phase. So I have the joint task force here. There have actually been other reports and other agencies that have looked at this issue long before the joint task force. So we are hoping to issue something. There is still quite a bit to happen. And notably, there is that coalition building. We all know that is part of our process. That is all being planned for. Once there is legislation, the idea is that implementation of that would begin immediately. And then there would be a launch. And then there'd be a little more time until we reach that stable universal healthcare coverage. Next slide, please. Again, I don't want to take too much time, but I do encourage folks to take a look at this. Again, Taiwan spent quite a bit of time doing really extensive design and background work and was able to implement really quickly. And these are a couple of the features that they really chose to focus on. That centralized IT was very important to them. And as I mentioned for that last piece in the integration area, though they did launch this within 8 months, they still spent some time to legally fold in some public programs and other revenue streams, and kind of equalize the benefits and the contribution amounts that were required under those programs to their universal healthcare program. Slide. Canada, I included as sort of a counterpoint, a much more incremental approach. This is something where they chose to do essentially hospital care first, and then they did physician care later, really kind of in 2 5-year blocks. The financing, this was provided as sort of a carrot, similar to how Medicaid got implemented in the US, where there was a federal match proposed for those provinces that expanded to the universal care. Next slide. So the key takeaway, and I've already said this, but the political and technical buildup tends to be slow and it takes time. It really can't be rushed. But once there is a model chosen, once there is legislation, it often moves fast to launch operationally within about 1 to 3 years. Now, there is one really, really important caveat, though, that was pointed out to me, and I would be remiss if I didn't mention it, which is that Oregon is not a nation in and of itself. We are a state within a nation. Therefore, we could expect maybe a few more complications along the way, because we do have to operate within federal rules as well. We cannot unilaterally make all of the changes. So that's something worth considering, but I think, the key takeaway still is long design, patience. But once there is a model, we could potentially expect that to be implemented quickly. And with that, I'll turn it over to you, Chair Blunt.
Thank you so much, Lee. That's fantastic. Yeah, and I'll add to that caveat, in addition to, Oregon having to operate within a federal system for healthcare payments. We have providers in the context of systems and insurers and hospitals, as well as businesses who operate in multiple states. And so for them to participate in this plan in Oregon would involve significantly more complications than if this were a national program, right? So they would have to carve out or make exceptions in Oregon that they don't do everywhere else in their business model. So that's going to add time and logistical complications to this model. And so we're thinking about that. Okay, so next slide, please. So our goal here.
It's not working at the moment, but
Oh.
the slide is progressed, but it's just not
Oh,
showing on our screen.
awesome. Do you need a minute or should it?
I think it's showing in the meeting, it's just not showing in the meeting room is the issue.
Yeah.
Awesome.
Yeah,
Oh,
it's
okay.
online.
Awesome.
Yeah,
Great.
online it's good.
So, on the next slide, we'll talk about the timeline and transition. And in this context, the transition that I refer to is the transition from our current system to a universal health plan. So thinking through like what that transition might look like in the context of a state within a federal system, and thinking through that. So, the reason why we need to think about this, the main purpose is, of course, to lay out the work in front of us so that the board has direction and a plan for the work ahead of us. But we do need to decide on a date where we project to the legislature when we think the universal health plan could be implemented. We need that for both revenue and expenditure projections, but also we need to convey to the legislature what we think a timeline would be to give them a sense of the work they would need to do in order to get all the state agencies and legislation involved prepared in time. So it's really important that we kind of estimate as best we can when we think a final implementation could happen, what's the transition work to get us there, and then use that date as sort of a road map. We also hope with this to address the extensive feedback that we've gotten about community engagement. We hear it, we understand it, there is a need for community engagement. We are in no way saying that there's not a need for that community engagement, but the timing of that communication is really important. So what we also hope to do with this conversation is kind of highlight where in the process that could and will happen. Okay, so in terms of our timeline, for the board, between now and September, there's a couple things that need to happen. We certainly have some remaining committee work to finish up on. There's some deliverables yet to be realized. And then we will be wrapping up the committees and taking all of their recommendations. And then this board is going to spend a couple of months, as Mimi pointed out, like Mayish, June-ish, maybe even April-ish, where the main focus of this board will be trying to reconcile all of the recommendations we've gotten from our committees. We've got to get the revenue plan to match up with the expenditure plan as the biggest one, but also there's so many other pieces of the plan where we've gotten recommendations from all kinds of places, and we need to come together and figure out how it all fits together into a unified plan. That's the work of the board in those 3 months and the work of staff, and we'll be very occupied with that. And then in the background and as part of those meetings, we need to think through more details of the transition of not only what the plan will look like, but how to get from here to there. We've started that process already. Judy and the operations committee sort of have agreed to sort of take on that work of thinking through all the details of that. And so that's kind of going on in the background already, but we need to be more explicit about that and have some better discussions at the board level about what that transition might look like. Of course, then we're going to finalize our report that gets turned in September. And then we need to work with the legislative committees and answer their questions, give them additional information if they need it. We're going to show up with this report. There'll be a lot of presentations and a lot of discussion. And our hope is that they take up something related to the Universal Health Plan in the 2027 session. At that point, that's where the board's work shifts to kind of getting the word out. Not only are we talking to legislatures, we're talking to all kinds of community groups and interest groups and trying to talk about this first version of a plan that we put forward. What would be beneficial about it? What are the downsides of it? Field everybody's questions and concerns and get reaction to it. And then at some point, once we have done that work, once the coalition building has happened, once we garner enough support for a plan, then legislation would need to pass in order for a universal health plan to be implemented. It could be one bill, it might be a series of 3 or 4 bills. There's a lot of moving parts to it, so getting that legislation passed is really key. So we'll get to that in a second, sort of what we anticipate in terms of a legislative process. But to lay out, to give you a sense of what we're already talking about in terms of implementation, what the steps are involved in implementation. So I'm on the next slide now. This is not by any means a comprehensive list. These are some big chunks of things that need to happen. And the reason why I want to go through these is I want the board to think about, as we go through these steps, if we have to do all this, how long do you think this will take to do these steps? So we need to establish a public corporation that will run the universal health plan. We need to seat a governance board. We need to draft federal waivers, work with our state and federal partners to request and secure them. We need to build the entire administrative structure for the plan, including redefining the role of the Oregon Health Authority, determining how the federal money will flow into the state. We have to contract with a claims vendor. We have to establish reserves and all the legal entities involved in running this plan. We have to establish an eligibility and enrollment process for current residents and new residents. We have to build a universal IT platform that will connect every hospital, every clinic, every clinician to this public corporation so that they can submit claims and be reimbursed. On the next slide, we need to sunset all the existing commercial health plans and transition their members from their current plans to a universal health plan. We need to determine the payment rates and strategies for hospitals, for primary care clinicians, for specialty care clinicians, and those will be 3 different processes. How we pay hospitals, how we pay primary care, and how we pay specialists will look different. They will feel different. There will be different strategies involved, and that's going to be very complicated and involved a lot of negotiations because there's a lot of variety in how practices currently exist and get paid. We need to transition 62 Oregon hospitals to global budgets. We need to transition 4,000 clinics to the UHP processes. So how they bill and process claims, their entire workflow structure has to shift, and there's 4,000 of them. There are 210,000 licensed clinicians right now in Oregon. We need to credential all of them to be able to pay them through a universal health plan. And that's a very long and difficult process. And then we need to educate them about how their payment strategies will be different, field their concerns and questions, and do some negotiating around that. And then, of course, there's all kinds of negotiations and conflicts that are going to arise. There will be legal issues. I'm certain there will be lawsuits. We'll have to dissolve health plans. We're going to change everybody's payment strategy. There's going to be conflicts. There's going to be issues that need to be negotiated and resolved. And we're going to involve a lot of legal processes with that. That's a brief list. I think there's a lot more that has to happen than that, but that's kind of what we came up with sort of off the top of our head for what needs to happen. So on the next slide, how long do you think all of that will take? 1 year? 2 years? I think 1 or 2 years is incredibly unrealistic. I think 3 or 4 years is extremely ambitious, possibly doable if we had really strong coalitions asking for it, but maybe 3 to 4 years for that transition, maybe. Honestly, probably closer to 10 years, but if we want to stay on the optimistic side, we can think about 3 or 4 years for that transition. And roughly that 3-4 years is kind of what we're operating on right now. So now in the next slide, for possible scenarios for legislation. So what could happen after starting at the 2027 session? So we're submitting our report in 2026. The earliest it will be taken up is the 2027 session. So the first option is the legislature could see our report and pass bills to implement the universal health plan in 2027. In theory, that's possible. It's extremely unlikely. Given the scope and the breadth of what we're talking about doing, it's highly unlikely that they would pass bills in 2027. They would most likely at least refer it to the voters. So option number 2 is that they could consider legislation in 2027 and opt to refer it to the ballot for the voters to vote on it. If that happened, it would be on the ballot in the fall, November of 2028. That's the year of the presidential election, of course. It would be on that ballot for voters to consider and possibly vote for. A third option is that the legislature could consider our report and then send it back to us and say, this is great. We're happy about it. We have 1,000 questions. We want to send it back. We want the board to continue its work and answer these questions or work out these details before we would consider legislation. That could happen. And then it would just come back to us for more work, hopefully with more resources, and we would take it from there. That's option 3. And then option 4 is they could look at our report, but make no decision at all. They could read it, say, thank you very much, and nothing could happen. That is a possibility. We certainly hope that doesn't happen, but that could happen.
Do you want questions at the end?
I'll pause here for a couple quick questions, but then I'll go into about this. Yeah, go ahead, Amy.
I'm wondering about the legislative champions that got us this far, thinking about Senator Manning, Representative Trump Nelson,
Absolutely.
and kind of the work to re-engage and continue and make sure that we have a legislative champion ready when we're submit the
Yes.
report, because of the time it takes to draft the legislation and all of that, so.
Absolutely. So yes, that is part of the work that staff and Judy and I are doing, is to make sure that we keep our key advocates in the legislature updated. So Rep. Nelson and Senator Manning are certainly top of the list as our champions and supporters, but we also talked to Rep. Nose, who's the chair of the Healthcare Committee in the House, and then Senator Patterson, who's the chair of the Healthcare Committee in the Senate. If a bill is to be taken up, it would happen in those committees. And so we have to work with those committees and their chairs and their staff as well. But yes, that's why we try to talk to them as often
Okay.
as we can. And we've been on that train this fall. Sorry, Cheryl, who's next? Go ahead.
So 10 years sounds super depressing to me, given that our healthcare system is crumbling at our feet at the moment. So I'm wondering, I wish Chenwei were here. How did Taiwan get it going in 8 months? I think that's what I heard Lee say. Is that Taiwan? Okay. Is it just that their system wasn't as complicated as the United States system? Is it because we're bigger and I don't know, just more complicated? Or because it seems like it has to be something, in my opinion, closer to 8 months than 10 years.
Yeah.
Like that just seems, I mean, then you just kind of want to hang it up.
Right.
But-
Well, so a couple of things on that. Do you want to take that or?
I can speak to a little bit of it. I'm sure you have
Yeah.
some things, but just to note, they spent the 10 years preparing, and candidly, that 10 years was a lot more intensive than what the state of Oregon has been doing.
Okay.
It was very intentional that this is what we're going to be doing. So they had a lot of work that went into it before that time. They were working on that centralized IT system during that design phase. That is part of how they were able to do an 8-month window there, because essentially all they were doing at that point was getting people signed up. And there had been a long buildup of the public knowing this was happening and building out those IT systems that they would want to use.
Yeah, and then don't underestimate the power of the fact that it was the entire country. Like if you're the entire
Right,
country
yeah,
and you're the
yes.
federal government, nothing else can exist. If the
Totally
federal government
understand.
says, this is what we're doing, this is what we're doing.
Right.
You know, as Lee pointed out, we are operating as one state
Yes.
within a federal system
Good point.
that isn't aligned with this, right? So
Right.
it's just a lot more complicated. I'm gonna just do a quick interjection here that this is why I believe, and Judy and the staff agree, that part of what we need to do is lay out some stepping stones, because we can't wait 10 years.
Mm-hmm.
We need to say there are some things that we could put in place now, this session, that would get us closer to a universal health plan, short of a full universal health plan, and that we could build on in order to get some of those wins a whole lot sooner than 10 years, because we don't have, we don't want to wait that long.
I'm sorry, just one other follow-up. what if we were in a coalition with California and Washington? Would that help? I mean, could we get it done faster?
So yes and no. I mean, certainly that would be a very powerful alliance. But can you imagine how complicated it
Yeah, that'll
would
be
be, right? So
complicated.
right now, we're looking at an enormous challenge to get Oregon on the same page to want this and make this happen. Oregon businesses, Oregon healthcare
Right.
industries, Oregon insurers, Oregon government, Oregon legislature. We've got to get the entire Oregon system to say, yes, we want this. That's going to be a challenge. I think we can get there. And if we do get there, how powerful would it be to bring those other states involved? But can you imagine like how much more complicated it would be and how much more negotiating? So
They were able to do it with the vaccines, right? I mean, so
yes,
I realize that's not as complicated as, yeah, but still, it's possible is what I think.
yeah, I suppose. Putting people out of business, right? Like, so we were
Yes.
talking about ending
Yeah.
commercial
Yeah.
health
I
plans,
get
right?
that.
And can you imagine the whole, right? So it just would change everything about how the healthcare system operates, right? And so it's a much bigger ask, but I think it's a fabulous idea. We've been talking about it since the beginning. We've talked to Washington and California multiple times, and that coalition would be very powerful, yeah. So Mary Lou was next, and then Michelle.
I just have a quick thing about, back on the credentialing line. My understanding, I think that we will be needing to work with the boards of the licensing boards to realize their job is much more important. And because when we started Care Urban, I understand about credentialing, but we're saying here, at least the understanding of the law, that all licensed people will be
Yes.
able, so it isn't gonna be as huge a big deal, because if they license them, then we
Yeah.
get them on, we don't have to go through a whole
Hopefully,
bunch
yeah.
of stuff. So it just was a little, I think it would be a little bit easier, hopefully, because that was one of my things that is
Yeah.
really a pain in the patoozie now.
Absolutely. Michelle.
Thank you, Chair. This is really helpful grounding conversation, and I agree with Cheryl's comments. I think that we have to strike a balance between being realistic and setting a timeline that continues to create pressure for the change that Oregonians need. So I don't think that I agree that it is, I don't see without a level of collapse that would create way more harm than good. I don't see a way of doing this in 1 year. In part because we know as a state working within federal constraints and wanting to create a system that includes federal dollars continuing to flow into the state and includes Medicare and Medicaid patients in it, that the current federal administration has pledged to not renew any new state waivers. Right. So that right there says anything before 2028 is a no. That's a reality. We can't ignore that reality, I don't think. And so I think that I would come down on like the 4 years. That does give us time. The federal waiver timelines are not set by the OHA, they're set by the federal government. We would need a different administration, a different CMS, a different Centers for Medicare and Medicaid services that would be willing to consider waivers in order to be successful. So I think that that's an important part of this timeline conversation, but I would advocate for 3 or 4 years to continue to put pressure to implement at the soonest possible time. I think if we say 10 years, that is too long. And I think that if we're not continuing to push ourselves and the state and the legislature, that this could end up on the back burner. So those are my comments.
Absolutely. And yeah, you came to the same conclusion that we did, that 3 to 4 year pressure point is going to be really key. So to be clear, it's possible it could take 10 years. We're not using 10 years as our timeline. We opted to try to land in that 3 to 4 year timeline. But we just want to be realistic about how much work there is to get there, but we're going to push for that 3 to 4 year timeline. Go ahead, Mike.
2 comments. One is to answer an additional answer to Cheryl's question, is that actually I've studied the timeline for many years. There's one fundamental difference that I would add to Lee's comment, and that is the culture is different. So either in Japan or in Taiwan or in Singapore, they spend more time in planning and much less at implementation. Our challenge is to figure out, do we have enough of a crisis so that we can find something compelling? It wasn't accidental that at the last meeting, I ended it by asking people to think about the next 10 years. And I hope that while we're trying to get a consensus here, if we act as if it's not compelling, it will be 10 years. And I'd say that in the Little Red Book, Chairman Mao perhaps had the best saying, which is a revolution is not a dinner party. If we act as if this is a stroll, we will get 10 or 20 or 30
Right.
years. I say that having tried to do some of these efforts in 1990,
Yeah.
35 years ago.
Right. Yeah, absolutely. 100% agree with you. By culture, I thought you have an excellent point too about creating that pressure and that narrative, which Lee brought up as well, that existed. I thought you were going to say also that there is a cultural piece around the role of government and the relationship between government and the population. And I think we have a different culture of that in the US than in Taiwan or in Canada or in the UK about the cultural perception of the role of the government with healthcare. And that's not to be underestimated. Okay, so these are the 4 possible scenarios for legislation. We hope the 4th one doesn't happen. We're not even going to talk about it. The first one is extremely unlikely to happen. We kind of landed on that second one as probably the most likely scenario. So if you go to the next slide, I laid out, so the first bit, I laid out like what would happen if legislation did pass in 2027. I'm going to skip that for now because I think that's extremely unlikely, but we did think through, what would happen in that case. But if you go to the second part where legislation is referred to the 2028 ballot, this is the most optimistic scenario I think we could have is that the legislature would consider it, refer to the ballot, it would be on the ballot in 2028. If that happens, then hopefully it would be approved by voters in November of 2028. And then the transition process of the state needs to get it into gear and start making this happen would start January of 2029. That's the very earliest it could start. So if we aim for that 3 to 4 year implementation timeline that starts in January 2029, 3 years would mean we implement in 2032. That implementation date for the UHP would be 2032 with 3 years to get there. That's ambitious, possibly doable, pretty aggressive, might be closer to 2033, but we could say 2032. So that's kind of so when we're talking about, what should we propose as like sort of our implementation date in terms of revenue projections for tax years, like what year we're thinking of, and expenditure projections, what year we're using. That's how we came to 2032 is through this thinking process of like, what's the most likely scenario for legislation? And then we would need 3 years. Now, to be clear, if there was legislation, what we would recommend is we would say, we recommend that the Oregon legislature begin transitioning to a universal health plan in 2029, right? Like, so starting January 2029, we want that to start happening with the goal of full implementation by 2032. So it's not like do nothing until 2032. It's like we have 3 years of an incredible amount of work to get into. And then, at the end of 3 years to implement in 2032. So this board has considered in the past an implementation date of 2030. That would mean we would be giving the legislature 1 year, 2029 would be the only year they have to do all of that transition work of setting up the public corporation and transitioning all the hospitals and clinics, like 1 year to do all of that to implement in 2030. So that's why we moved from saying that our implementation year is 2030 to 2032. This is the process that we came to. We wanted to kind of lay out kind of where that came from. So next slide. So, right. So this is, sorry, I forgot that I had this slide. So even if legislation did pass in 2027, which it really likely would, we would need a minimum of 3 years. We could propose implementation as early as 2031, but then with the federal waiver situation from our OHA colleagues saying that federal money wouldn't be available in 2032, even with legislation passing 2027, it's unlikely we would get there. until 2032. And then if the UHP is referred to the 2028 ballot, implementation wouldn't begin until 2029. The earliest we could have full implementation is 2032, which would give us 3 years for that implementation phase. So next slide. Oh, sorry, Amy, I didn't see your hand. Sorry. Go ahead.
I'm thinking about our current budget and our current resource model with free staff and a volunteer board. And at what point in this process that would change, like where are we gonna get the manpower or the person power to, you know, in this process, like with our
Yes.
current reality of
Yep.
budget and resources.
It's a great question. So, yeah, so again, the legislature could, when they pass, if, so most optimistic scenario, refer to the voters and get started. One thing that they could do is seat a full-time board. Or they could say, we're gonna give this to a new federal agency and have them build it from here, right? Or, I don't know.
State.
Sorry, I apologize. State agency. Sorry, yes. Sorry, state agency.
Okay.
Yeah. So like so it would be up to the legislature to decide how to resource the work. I don't know,
But
but
we
we're thinking through, and we'll come up
We'd
with a
ask
proposal.
with that.
Oh, of course, yeah. Yeah, we're thinking about
Yeah.
that. We wanna keep.
Yes.
So, yeah. we
It
would
just
be
seems like
thinking
it's
through
one
that.
part of the
Yeah.
conversation. in
Right.
this, Because otherwise it's kind of fancy.
Exactly, yeah, exactly. Next slide. So, I am wondering if the board would consider a motion, and somebody would need to propose it, to recommend beginning the process for a UHP in 2028 or as soon as possible thereafter, likely January 2029, with a target date for full implementation of UHP in 2032. And cost projections will be for the 2032 target year. Is there a motion for that?
Chair, I move to propose the UHP will recommend beginning the implementation process for the UHP in 2029 with a target date for full implementation of the UHP in 2032. Cost projections then will be for the target for 2032 year.
Is there a second?
Excuse me, did you say 2029?
I did.
Okay, it says 29.
I was making my own motion.
Oh, I see.
Yeah. Do you wanna, so there's a motion to edit the motion that's on
Oh,
the
got it.
projection to begin implementation in 2029. So it went away. Goes with challenge.
I listened to Chair.
Yeah.
So go back to where you were and I will, I'm gonna try and put it on a Word doc, because I can't access my slide at this moment.
Clarified here.
Yeah, so the original motion that was written was to begin implementation in 2028. Judy made a motion to begin implementation in 2029 with a full implementation in 2032 and cost projections for the 2032 target year. So that's the motion that we're considering, 2029 implementation begin date. Is there a second? Okay, well, seeing no second, does somebody else want to propose a motion for our timeline? Go ahead, Mike.
I propose, the proposed motion as written.
Okay, so you want to propose that the UHPGB begin implementation in 2028 with a target date for full implementation of 2032 and cost projection for the 2032 year?
Yeah.
Okay, is there a second to that?
I'll second that.
Judy second. Is there any discussion about that?
It just, I'm in favor of as fast as we can.
Mhm.
Okay, and I think you are too. I think everybody is. But this whole thing about the 28, you know, if there's a vote, I could see Judy's point if, you know, it's voted in the end of 28 in November, then was it me? Started for Christmas, okay, but it was very realistically, but I guess this feels like it's a little bit.
Yeah.
This is them choosing to take action and not to vote.
Yeah. I guess in theory, the way I could see this working is if the legislature considers it in the 2027 session, says we're referring it to the ballot. they could still put some things in place in 2028 before that happened. They could think about
Yes.
things like how they would transition some hospitals or how you build a statewide IT plan, which would be,
Yeah.
right, regardless of whether or not the bill passed in
Yeah.
2028. There still could be things
This.
that the legislature could do in advance of that going to the ballot. So
Yeah.
that's the way I would think of it.
Yeah.
Yeah.
I'll second.
So it's been moved and seconded. Is there any other discussion on it? Okay, let's do a roll call vote.
Ellen Belanca,
Yes?
Chenwei Chi is absent, Amy Fellows.
Yes.
Michelle Glass,
Yes.
Goldberg is on leave, Judy Richardson,
Yes.
Cheryl Ramirez.
Yes.
Mary Lou Henrich,
Yes.
Mike Leahy.
Yes.
Thank you. It's everyone.
Awesome, thank you. Okay, so moving into the next section, which is. Oh, sorry, I apologize. So Mary Lou at this point wanted to propose some motions, so we put them up here for consideration. So Mary Lou, I'm gonna turn it over to you about if you want to go ahead and make these motions.
Yes, I think, oh, it's not yours, okay, all right. My eyes here, okay. I guess just a little context, and I won't take a long time, but part of the reason for these motions is that I, as a board member, feel very rushed when we're considering things like this. And I can hear the, urgency in your voice and that we've got to get this done, we got to do it. And so I guess maybe the one that at least down there about adding 30 minutes to our board meeting or something that kind of lets us have this dialogue. I think that I felt like our meetings are just packed with, we've got to vote on this, we've got to look at this, we've got to do this. And then we end up cutting short sometimes the public testimony. And anyway, I just am feeling like if we had just a little more breathing room, because I think it's really important for me to hear what other people are thinking for us to really have that discussion. And we did here, but I felt it still was rushed. So, but back up the very first motion there that I'd like to propose if someone would move it is that I would also like to feel that as board members, especially we're getting to the kind of the climax of these committee meetings. And some of us have been watching other committees than we really belong to, that, and maybe have a question at that, and I'll give my example of the plan design meeting, where this last one, as the contractors were talking, as Fritz was talking, et cetera, that I felt I had a couple questions, but I couldn't ask them because I'm not a committee member. So I'm wondering whether we have a rule, and if we do, if we could change it, or if it's just a practice that board members who want to sit in, and there may be a board member who wants to sit in on the finance committee and ask a question, et cetera. I think that would help us down the road if we, had a little more of that cross-pollination ability at committee meetings. The other alternative I've been told is, Mary Lou, you can join those committees, and I can, and I probably will if this isn't passed, because I really would like to be able to interact. But I feel like that kind of gives an impression if you go to the web page about who's on the committees, and my name is there, but I'm really not a full participant. I mean, whatever, I feel kind of weird about having my name listed there and people saying, oh, I hear you're on the such and such committee, and well, kind of, but not really.
Okay, so Mary Lou, do you want to
Okay.
propose a motion?
So I would propose the first motion that all board members are able to participate at any of the committee meetings by being able to ask clarifying questions and or offer input like other committee members are empowered to do.
Is there a second?
So
Mike seconds it. Is there discussion? Discussion. Go ahead, Judy.
I don't support this motion because as the chair of operations committee, I'm very protective of my committee members' time and engagement, really want to hear their voice and thought. And they've been with the committee as long as they've been appointed, and most of them since the beginning of the committee. So much of our work and our straw proposals build in a scaffolding way. And my expectation is committee members who missed part of that will connect with me to be brought up to speed so that they're ready when we have our committee to do the work of the committee. If board members are chiming in haphazardly or not paying attention to the work of the committee, I think it's both distracting It's inequitable because the committee members have put in the work in the study to contribute in a way that I want to hear their voice. There are multiple ways that board members can reach out and contact a committee chair, asking questions. Between meetings, you can send a one-to-one email asking a question about the proposed agenda or about meeting minutes that happened before, listening in, making notes of those questions, and then reaching out to the chair, which is why I wouldn't support this.
Michelle?
Thank you, Chair. And thank you, Mary Lou. This is really thoughtful, and I understand where you're coming from. And I also share some of Judy's concerns as well. I, for example, was finally able to sit in on my first Finance and Revenue Committee meeting in December, and it was really enlightening. But and I did have questions, but I was very cognizant of the fact that this committee had been meeting for months and I hadn't been there and I hadn't watched all the recordings and I hadn't read their past materials. And so I wouldn't feel like it was fair to the committee or the work or the public, right? Like we have a sacred charge to develop this plan and to do it. That's already been delayed twice, which has then delayed more opportunities for broader public engagement, which is creating a lot of frustration for members of the public, which is understandable. And I don't want to slow down the work. So what I did is I wrote a public comment that I'm working on getting submitted, just like any other member of the public that was watching that committee meeting, because I'm not a full-fledged member. I think the other question that I have is how that might muddy the waters when it comes to voting on topics in committees. If any board member can pop in and be seated as if they were part of the committee, then how do we handle voting? Are they voting members? How do we make sure they're up to speed and have all the context? I understand the impulse and I really applaud the amount of time and energy that you're able to put into this, Mary Lou, and that you do put into this because you care so deeply and the expertise that you bring. And I'm not sure that just making the process that open supports the work and supports our responsibility to the public. So I'm also not in support, although I understand where it's coming from.
Mike?
So I think this is a good debate and I think I understand both issues, but let me share with you all. I was the person that was attending the meeting and tried to be helpful because it was written, there was a particular motion written in such a way that when they meant a 10%, and maybe Lee can help me with this, but it was written up in such a way that you could read the motion as it was going from, the intention was to go from 30% to 70%. And I was trying to contribute that maybe you want to just have the motion clear that it's not going from 30% to 40%. And I was told, like, you're out of order. I mean, I think we've got to figure out how to have some level of flexibility, especially when some of us might see something. That said, I totally understand Julie's perspective. I mean, I think there's a tension here, but if some of us maybe have some experience or see some things, by not allowing a board member to do that, that has a cost too. And I just think we all need to wear that, because there's a lot of truth in both perspectives.
Yeah. So just to clarify, I really appreciate that, Mike, and you did have super important input. As Judy said, you can do a one-on-one with the chair after the meeting and say, hey, that wasn't clear, maybe this. And then this board always considers all of the proposals brought by every committee. And during that discussion, you could provide your input then. So it's not that board members can't provide input. It's just that we're talking about whether or not they can chime in the moment during the committee meeting. But there are other opportunities for board members to provide input. Yeah.
I think everyone said what I would say. I would just say it's the board meetings where we have the opportunity to provide input as board members. Yeah, I agree with that.
Any other discussion? Okay, let's do a roll call vote.
Helen Blanca,
No?
Shenwei Chi is absent. Amy Fellows,
No.
Michelle Glass,
No.
Bruce Goldberg is on leave. Judy Richardson,
No,
Cheryl Ramirez.
No,
Mary Lou Henrich,
Yes.
Mike Leahy.
Yes.
That's everyone.
So the count is, five, what are we now, 6-2?
5-2, yeah.
5-2, because John was missing, 5-2. Okay,
Okay.
that motion fails.
Okay.
Do you want to propose another one?
Well, and the next one is maybe, even more important to me, that we add a little bit more time to the board meeting. I wasn't here at the beginning. I said, I'm in the middle of the movie. But the 3 hours feels very rushed. If you look, we're behind now on the agenda. I'm starting to have heart palpitations. And, so if we had, I'm wondering if we could beat until 12:30. I'd really like an hour.
So
That's my
proposing adding 30 minutes to all of our.
30 minutes to the
Okay.
board. To the board.
So that motion's been proposed. Is there a second?
Second,
Any discussion? Go ahead, Cheryl.
I'm fine with that. I just wanted to state the caveat that if it interferes with my day job, I will have to leave at times, but well, I'm totally open to that.
Any other discussion? Go ahead, Judy.
I just want to mention for the board's benefit, some of the interstitial work that happens that's around the board. And so Helen and I debrief after board meetings, which often keeps us here for another hour after a board meeting. And so that would be additionally delayed. And my concern is the same as yours, Cheryl. Sometimes I have to get back for work. And so that is not going to be possible. And I see my role on the board as doing most of the work prior to the board meeting and coming ready to make votes, only occasionally to be swayed by the presentation during the board. And maybe that's the wrong approach, but I think that helps not feeling so rushed. That's just my thinking.
Any other discussion? Sorry, Michelle, go ahead.
thank you, Chair. I agree that preparation is key and there's no other way to get through these meetings, but without being really familiar with the packets. In addition, though, I think that as a board, like the reason we're a board and not a single individual is because we bring diverse perspectives. We bring professional perspectives, lived experience perspectives, regional perspectives. And in addition, there's public comment that's submitted beforehand, but there's public comment that's presented at the board meeting before we vote. And I think that it is important, especially with the heavy lift that we just covered, that we not only read the written materials and have our own thoughts ready, but that we come open to the perspectives that the public may bring. And I learn from each of you. Like, I really value dialogue and hearing how other board members thought about or reflected on, or what experience they had to apply to whatever the topic is. So for that reason, although I hear the constraints and I understand them, I also work full-time and have a family and all of those things. I think 30 minutes once a month to me seems like a small movement towards creating more space to hear each other and consider those perspectives while we're making these important decisions. So thank you, Mary Lou, for bringing it forward.
Any other discussion? I want to invite the staff to chime in anytime we talk about meetings and logistics. I think it's really important to consider any opinions or input from the staff on this motion.
Thank you, Chair. I appreciate that. So what I would interject in terms of adding 30 minutes, or, well, I'll just add that to this. I think there is the potential for adapting the meetings to be more efficient. So there certainly is time spent that is perhaps not as fruitful as some of the other opportunities. I will say that in terms of meeting efficacy and efficiency and people's ability to concentrate, and certainly the effort that goes into it from the staff having longer meetings does not always mean that they will be more productive. And at times people tend to then take up more time and become less efficient. So I will say, in consideration, when you're thinking of these motions, consider the additional work on the staff time, which we are working very hard, love our jobs, but we're a small staff and working hard to keep afloat what we have. Thank you, Chair.
So I would just add to that, sorry, Was somebody reporting? Go ahead, Lee. Did you want to jump?
I was just going to say, I strongly support what you just said, and, I've actually done quite a bit of research. I have a master's in like organizational and in systems learning, and longer meetings do not mean more efficient. They need more opportunity for bloat, so
More opportunity for what?
bloat.
Yeah.
Go ahead. I think that we need more dialogue. And I just wanna, on a timing note, ask, and related to this, if we could switch one of the agenda items, because I know Michelle has to leave at 11, and I'd like both of us to be here for our report out, so just when we get through these motions, if maybe we can do our CDCC update before the next agenda item.
Okay, so let's consider this motion first and then we'll talk about that. Yes. So I would, just add that I 100% agree that dialogue is super important. Right now, the bulk of our meetings is taken up by committee reports, as well as educational topics that the board has asked for. And I anticipate that very soon, possibly even by February-ish or March-ish, we won't be having committee reports because the committees are going to be wrapping up. And so our meeting structure is going to change dramatically in early spring, and we will have the entire board meeting for discussion. That's all we'll be doing is discussing and trying to reconcile everything we've learned from the staff, from our committees, into one cohesive plan. So we'll have 3 hours of pretty much pure discussion fairly soon. So I agree, we need more discussion, and I think it's coming. And we're just kind of limited right now because of the committee reports, which are super useful and helpful. Okay, any other discussion on this motion?
I could amend it. That we do this for the next 3 meetings and then reassess. And if we aren't having all the other stuff, so it isn't feeling so pressured and there's time for dialogue. And we could go back to that, and also it wouldn't have to be necessarily the 30 minutes at the end. We could add, start 15 minutes earlier and 15 minutes later or something. I don't know, but I was trying to respond to.
Okay, so you can withdraw the motion and propose a new motion, or we can just vote on this motion and then realize there are other options.
We'll just vote.
Okay, so we're gonna keep the motion as it is to add at least to add 30 minutes. I'm gonna remove that at least because that's confusing. So we're gonna add 30 minutes to each board meeting. The motion's been proposed, 30 minutes each board meeting for more discussion. It's been moved, it's been seconded. Is there any further discussion? Okay, let's do a roll call vote.
Ellen Belanca,
No?
Shenwei Chi is absent, Amy Fellows.
Yes.
Michelle Glass,
Yes.
Bruce Goldberg is on leave, Judy Richardson,
No.
Cheryl Ramirez,
Yes.
Mary Lou Henrich,
Yes.
Mike Leahy.
Yes.
That passes 5-2.
Okay. So we will talk with staff and figure out what that timing is, like when it'll start and when it'll end. I want to get their input before we do that, but we can consider that, and we'll send an email out to clarify the timing of our next meeting. Cool, okay. So Mary Lou, I'm gonna say that, it's time for break, so I'll say, do you want to propose more motions? And if so, we might need to take a break and come back to them afterwards.
And I wanna also.
Yes, about the timing. Now, let me finish with this first, and I heard you, yes. What do you think, Mary Lou? Do you want to propose more motions, or are you?
Well, I guess I can propose, I really have been listening to the public testimony about the fourth.
Apologies. It's a yes, no, because if you are, we'll do it after the break.
Okay, let's do it.
You're gonna do, so you do want to propose,
Yeah.
okay. So when we come back from the break, since Michelle has to leave at 11.
Michelle's hand was.
Yeah, go ahead, Michelle.
Do check first.
I was going to address these last 2 bullet points, so I can do it after the break.
Okay, so let's see, I'm gonna check the time. So it's 10:30. Michelle needs to leave at 11. So I'm gonna defer to Michelle and Amy. We can either do the committee report out now, so that you have time to get to your next commitment, or we could do a 10-minute break and come back at 10:44 and you could start then.
I do not like being in the way of people's bio breaks. I think that we are all humans, and so yeah, let's do a quick break, and then
Okay.
we can come back and do that.
Okay, please everyone, let's be back by 10:44. Thank you. Thank you everyone for coming back promptly. I appreciate it. Quick adjustment to the agenda. Next, we're going to talk about the CECC committee report out, and then we're going to return to Mary Lou's proposals, and then we'll proceed with our agenda, which is the revisiting principles discussion, and then after that, finish with the remaining committee updates. Okay, Michelle and Amy, I'll turn it over to you.
Okay, great. So I'm gonna start. So the Communications and Community Engagement Committee was the first of our committees to begin work back in October 2024. And we have completed a substantial amount of proactive groundwork. When the board work plan was initially developed, it assumed that a draft plan would be ready by spring 2025, so that community outreach could begin. As the board is aware, the timeline has shifted several times, which is understandable given the complexity and scope of the work. Because meaningful community engagement requires something concrete for people to react to, the CNCC's outreach phase is dependent on having a draft plan in hand. For that reason, we paused our community engagement contractor in spring 2025 and brought her back in November, with the current expectation that a draft plan will be available by February 2026. This is also why the CECC did not meet in November or December. At this stage, the committee has completed all of the proactive planning, input gathering, and materials development that can reasonably occur without a draft plan. In January, the CECC will meet to receive updates on the board's timeline for completing a draft plan and a check-in on how engagement planning is progressing with Diana. Beginning in March, the CECC will resume regular monthly meetings to plan for broader community outreach once the draft plan is in hand. And I think the next slide, so the milestones to date from our first CC meeting, that we reviewed engagement reports from the prior task force, onboarded communications and engagement consultants, placing one contract on hold, the deadline shifted, reviewed some feedback and public input from across Oregon, developed foundational communications materials, brainstormed which communities and stakeholder groups should be included in engagement, and developed draft engagement questions tailored to different groups. So that's just kind of update up to this point. And Michelle.
Thanks, Amy. And thank you, Chair and Board, for your flexibility with the agenda today. Appreciate it. So as you can see on the slide, this is a brief overview of where we are at. There's been a lot of great questions about where we're at in the process with planning with Artemis Consulting for the 10 targeted engagements, and then also what the timeline is for coming back and doing the planning for the broader engagement that we'll be able to do within our constraints. So this is the scope of the engagement that Artemis Consulting is doing. So you can see the list here, and these are per legislative direction to fill in the gaps in engagement from the previous engagement work that was done with the task force before us. So the legislature said, great, we love the engagement the task force did. These are some groups we haven't heard from yet. We want to make sure that we do get some feedback from them before we get a draft plan submitted to us. So that is what we hired Artemis Consulting to do. So her contract is not for a full engagement process. And so even within these 8 categories, we know that we're not going to capture the full diversity of perspectives given the size of each group and our resource constraints. So again, we're just really trying to meet that legislative direction. So what Artemis Consulting is going to do is have multiple forums for some categories, such as the community-based organizations and the consumers. And then some other groups might only get one listening session. And that, an example might be the coordinated care organizations. These will be virtual meetings, and they will have approximately 12 to 15 people in them each. So they will be capped because we want in-depth feedback from folks, right? This is not a check the box process. We want people to surface concerns and give us, have the time to process and really share. And we know that when we get more than 15 people in a room, the level of engagement goes down. So that's a quick update on who Artemis Consulting will be engaging next year. Next slide, please. This work is just getting underway. So as Amy shared, we did bring Artemis Consulting on early 2025. The original really optimistic plan was that we would start engagement in the spring of 2025. We didn't have any proposals, even any straw proposals to bring to the public at that time, so it wasn't appropriate. So we put her contract on hold. So she's just coming back, and she's spending November, December doing review of the work that the board has accomplished since she went on pause. And that includes a review of all of the feedback that CECC has given, including a list of groups to engage with. There is still time to add to that list. So there are some CECC committee members that are adding some additional groups and names to that list as we speak. So there will be time for Artemis Consulting to consider those suggestions. Artemis Consulting is also meeting with staff in December to really get a sense of where each committee's work stands, what's been approved, what's under consideration, what is yet to be fleshed out. And then in January, Artemis Consulting will be meeting with committee chairs and board members who participate in the various committees that are drafting this plan to say, here's what I understand about where the work stands. Here's what here's what I'm thinking we can bring out to engagement. And what else, what do you think is really important to ask in these meetings about your, whatever piece it is, if it's finance and revenue, about the finance and revenue plan, if it's plan design, if it's operations, and then asking also if board members in those committees doing that work have specific groups or recommendations for groups to consider engaging. So that is going to happen in January. So you will be getting outreach for those meetings for January of 2026. The engagement is anticipated to happen in March and April, maybe late February, depending on how quickly the board is able to move towards getting some things finalized out of committee and finalized at the board level. And so again, this is in the planning stage. Board members and the CECC committee input is the first foundational pieces that are going into this planning process. And so we welcome your suggestions. Any board members who have suggestions today that you don't want to wait for those meetings to give, you can email those to staff and staff will get that to Artemis Consulting. So want to clarify that. And then on the topic of broader public engagement, I think a lot of people think that we're at that, well, my perception from conversations I'm having is that a lot of people are afraid that we're at that very last part of this long phase that Lee just outlined for us. And we're about to go live with the new plan. And no one will, there's lots of people who haven't had a chance to have input yet. That's definitely not where we are at. So want to stress that community engagement has been part of this process for decades. I know HCAO folks are in the room. You all have been doing engagement. I, as a baby organizer, community organizer in my 20s, I attended meetings in Southern Oregon where, folks were telling me about Oregon's path to universal health care. And I, really value that work. There was the task force, there were the bodies before the task force, there's our board, and then there will be work after this. So what is different and unique about us versus those earlier engagements is that it's really a different thing to engage people on the vague idea of universal healthcare in Oregon versus something that is specific and grounded and could actually go into implementation. And in order for us to do something different and move the ball forward, we need to do that engagement. In order to do that engagement, we need the specifics, right? We need to know what we're engaging people about. We need to have answers to people's questions. And we need to tell people, yes, we've considered that. Here's what we found. What do you think, right? And so that is why the engagement piece needs to happen after the committees, bring forward their straw proposals and the board is able to agree to some at least initial ideas that we can take to public engagement. It is really crucial. Otherwise, we're just repeating work that's already happened and we're stuck in a cycle and we might not meet our timeline to deliver a final plan to the legislature for them to consider. So in March, the CECC, we are hoping by February, again, that the board will have had a chance to solidify some of these plans from plan design, operations, and finance and revenue. So in March, that will be the first opportunity that the CECC will have, the earliest opportunity the CECC will have to know what that looks like and to start planning some additional activities, within our timeline and within our resource constraints for how to engage the broader public. That is the plan. So anyone who wants to submit ideas to the CECC or attend and watch that March meeting, we welcome you. We welcome your ideas and your input. But that is, those conversations started again in 2024. We had some in 2025, but without knowing when and what the draft plan looks like, it was very difficult to make a grounded engagement strategy and plan. So there will be additional broader engagement that will start the planning in March and will start happening in the spring and summer of 2026. That is feedback that will be able to be incorporated in the report to the legislature in September. And it's not the end, right? The other thing that the CECC has the opportunity to do is to also make some recommendations to the board on what the next phase of broader public engagement looks like after September of 2026, because the board's work will continue. And that is when we will have something much more solid. And that is when we can ask the legislature for the funding that would be appropriate for a much broader outreach plan. So I hope that that is helpful. One thing that we're also going to be looking forward to is widening the circle. So we know that each of us as board members have people that are within our sphere of influence in our networks who we can share about the work. We know that HCAO does great outreach. We know that there are people in Oregon that HCAO doesn't have touch points with, that I don't have touch points with, that none of my fellow board members have touch points with. So we also need a strategy for how we widen the circle beyond the folks who already know about our work or are likely to connect with one of us as individuals or one of our organizations that are engaged in the work. So again, please send your suggestions or attend that March meeting. And I hope that that is helpful and clarifying on the timeline. My final offer is, I know from Amy and I've been plugging into some of the other committee work to get up to speed. And it looks like there's some questions about this timeline and process for community engagement popping up in committees. So if it is helpful, we are happy to come and do a really brief overview at the committee meetings and answer questions and be available in that way. So committee chairs, please let us know if that's helpful. If that's not helpful or you don't feel you have time, let me know if you'd like a written summary and we can email that out. Thank you.
Thank you so much, Michelle and Amy. Appreciate that. Any questions for them?
I guess I have a question. Mike Huntington's idea about a broader engagement, his little plan, I read about it and then I heard it testified to today. Just wondering if there is any, will the CEC think about that or talk about what will happen? I'm never quite sure when this testimony is given exactly where it goes to and how it gets responded to.
Michelle and I have not had a chance
yet
to discuss it. So I think.
But will you? I mean, is that where it goes in our process? Or does it go to Mimi? I mean, where?
I mean, yeah, and public comment our suggestions that we hear and we look at and consider, right? So I think that, and that one also came with a budget.
Yeah.
So.
I mean, it's sure it's not just one group or one person or whatever, but that was probably the most concrete proposal or something that I have seen about something.
So, and again, we have to consider where we are in the process in terms of.
Yeah, I mean, I just want to know that you guys will take it up.
Say that I encourage all board members to hear and listen and read all the public comment that we get and consider it. But when it's particularly, if you're the chair of one of the committees and it really relates to your committee, I'm sure that those chairs will consider it and work it in as needed as they determine fit. So yeah, I assume that Michelle and Amy will read through that and give their full consideration. Yeah, go ahead, Michelle.
Yeah, I was just going to say absolutely. There is a running list that I keep that's a summary of public comments that relate directly to the CECC work. And anytime there's public comment that comes in that is really directly oriented at engagement or communications, we generally, bring it up in our meetings as in planning CECC agendas. We bring it up with our contracted consultants if it's appropriate. We did that in November. So yes, Mary Lou, the answer to your question is that is part of the process. Thank you.
Okay, any other discussion, questions? Okay, great. Thank you so much, Michelle. Sorry to keep you a little late. At this point, we will go back to interrupt our committee updates and go back to Mary Lou's proposals. And I'll turn it over to you, Mary Lou. Do you want to make another motion?
Oh, I have been told that, you know, the budget and limitations on travel and a variety of things. So maybe these last two motions, I will wait and maybe do it another time. I'm not sure. It just, I guess my issue is just trying to get out there as much as possible. I hear and do understand what Michelle and Amy have been saying and all these pieces. I just don't want to look like I'm kind of a loose cannon here saying, let's just continue whatever. But I am concerned that when I did hear Mike Huntington's presentation and read it last night, that just kind of letting the word kind of know that this is even going on and that awareness place. And so anyway, that's the last two really had about, you know, could we make other communities more aware? But I understand the constraints. So I guess I will go forward with those.
Yeah, and I mean, as an idea, you could kind of bring them or write them up and then the CPC, so you can kind of consider them.
Yeah, okay.
I mean, yeah.
Like I said, coming in the middle of the movie is a little hard because things have been going and previous things, and I've tried to update myself as much as I can. But it's still some of these processes.
I think you're not new anymore. I think only Mike knows that.
Yeah, I know, but I'm saying I was.
And I'm
so-
feeling used, but.
So anyway, that's
Okay.
all.
All right, thanks, Mary Lou. Would any other board members are interested in proposing a motion in terms of our process, our meetings or our engagement process from now? I just want to, Mary Lou put these to the staff and I ahead of the meeting, so I wanted to make sure to give her time, but I'm open if anybody else feels like we need a motion about our process.
It's, as the designated person now, I'm, my impressions, right, have been that maybe for the first year or so, there was not as much progress as people anticipated there would be. And maybe the train was going, 20 miles an hour. But as someone new, I feel you're going now at about 40 miles an hour, and that's so the pace is different. And my only reflection is, I want to say this in a positive way. I think Oregon deserves, and the board members here in the community deserve a high performing board. So I think the spirit of what they were saying is that let's just keep some flexibility and respect one another and try to be high performing. That said, I think there's too much bureaucracy now in Oregon with all these rule things. I mean, the fact that we can't respond to the public's ideas when someone has an interesting thing, there's something that doesn't work with that. For me, unfortunately, I'm not wise enough to have a solution for that one as much as maybe the fact that the committees will be not being eliminated, winding down. Maybe that will allow us, but I've been a part of ill functioning boards and I've been a part of high functioning boards. It's much better if you're part of a high functioning board. So I would say for 2026, let's all figure out how we'll all do our homework. We'll all do the best we can. We'll keep flexibility. This is really bare of a task to do when we don't even know certain things about the federal government. Maybe this is really mountain climbing. So maybe if nobody wants to waste time, but at the same time, the more respectful we can be, the more we can say that we want to disagree and we want to hear other perspectives. And if we have that kind of tone out there, I think a lot of this community engagement stuff will go much better than something to candidly appears to me to be well-meaning, but a little bit rigid.
Yeah,
That.
we're walking the line. We're trying to do our best with following public meetings law, which is
Yeah.
crucial for a public board like ours. And getting our deliverables done on time and doing it in the most efficient way possible. So yes, we will continue to follow the public meetings law regarding the role of public participants in our meetings. And try to work through our process. Thank you. Okay. I'm gonna change my mind. We're gonna table the tax and principles discussion in our next meeting. I want to make sure we give the committees enough time to give us an update. So if it's okay, Cheryl, we can switch to you and we can do a finance and revenue update.
Sure, and I first want to invite my committee colleague, Richard Gibson to the table.
Check the seat we're right
Okay, great, thank you. So what I'd like to do with our report is start with just a summary overview of where we are with the committee. I'll do that. And then if you can just save your comments and questions until I get through that, I'd like then to turn it over to Richard and Mimi mostly, who can kind of do more of a deep dive into details, which I suspect you will be asking about. So that's okay. That's how I'd like to proceed. Okay. So we kind of bucketed our components of the proposal into three categories. So there's category A, and this is a category in which we just need final confirmation. So I'd love to make sure you are all in agreement with us. I can tell you our committee has consensus on these two items. The first one is the household size rate readjustment. So we would be replacing the per person premium. We heard that sounds like a whole other tax and it's confusing and all that. So we're just looking at household size adjustments. That's the first thing. We have consensus on this. We also have consensus on allowing a 100% Medicare Part B credit against the HCPIT. So committee is all on board with that. And that, again, we just want to make sure the board is okay with that too. So next category B. These are proposal elements that we wanted to update you on. And I wanted to also add that we have consensus on all of these items as well. So we all agreed that there should be a lodging tax to cover visitors. We also agreed that we're just not going to include a sales tax in our proposal, but we are showing our work, so to speak. We are showing you what it would look like if we did include sales tax, just so you can see the comparison. We decided that the consumption taxes would not be included. You know, just to be kind of informal about it, the juice wasn't worth the squeeze. So we all agree that we're not going to include that in our proposal. And then last, the EPT structure changes include the removal of an individual level wage deduction and a small business exemption of 500,000 in payroll threshold. And I think Mimi really explained that earlier. So, but if you have questions, you can ask. So again, these four things, we have consensus from the committee on all of those parameters and proposal elements. Okay, third category C. This is the one that's squishier. We do need direction from the board. We're continuing to develop these elements. The first one is the EPT tax credit level. I think the last time, at least when I was here presenting, we had it at like 40%. We decided to look at a little bit of a broader range. I believe there may be three scenarios, 30 to 60%. So working on that, but we agree on this concept. Second, the soft cap mechanism. We voted on this in our committee, And the majority voted to take out the soft cap mechanism. So it's not included, but like the sales tax, we'll be showing our work. So you can see a scenario with soft caps versus no soft caps, just so you see how we made that decision and see if you agree, of course. And again, that's on our proposal. We know we don't make the decision as a committee, but this is just what we decided to put forward. The HSRR rate, shape and parameters, we are modeling the rate structure right now. Again, you know, we don't have that finalized, and we need to work it out in our committee to even give you a more specific proposal. And I know that Richard's going to go with some of these more in depth. And then last, the personal ownership. This is whether we believe that low-income households should contribute at all to their health care. And we were kind of talking about maybe over 138% federal poverty level or 200% federal poverty level. That was actually my thought, the 200%. So we're not there yet, and I understand just from a recent email that we probably won't even get to this at our January 6th meeting. So that might be something we have to move to February, is my understanding. In addition, we are testing all of the scenarios for the Medicare population, as well as the self-employed and the insured by, you know, employer insured. So that was a good suggestion by one of our committee members, and that's what we're doing. And I don't know that I don't think I've seen the final on the Medicare. I would imagine we're talking about it at the January 6th committee meeting. I wanted to also mention, I hear the public testimony on our proposal not being progressive, but we believe that with no soft cap, all of the EPT credit options are progressive. And I know Richard will go into that more. I also think that there have been challenges with the lag on updating the meeting materials. And part of that is because our committee, you may or may not know, has been meeting twice a month. And I think it's really difficult for that core group who's working on all the modeling, all the estimates, to get that turned around in a week so it can be posted a week in advance. It's almost impossible. And I do want to give credit to Richard and Charlie, and of course Echo Northwest and Mimi for trying their best, but it's really difficult. So I think potentially some of the public comment that we received was from a prior iteration. So just want to mention that. Okay, next I just wanted to go, I'm not going to really talk about, I'm not going to say a whole lot about the transition costs. And I might bounce that, or the reserve funding, I'm sorry. Because it seems like it's dependent on what we come up with. And so it was like, it could be this or it could be that. The one thing that is concrete is that there's a one-time cost ramp up and ongoing costs, or ongoing, costs. So that's all I'm going to say about that. Then I want to jump to the timeline and hand it over to Richard and Mimi for anything else you want to add.
Sure, can I ask you a question?
Yes.
On category C, number 1,
Mhm.
EPT tax credit level, and the green check implies agreement of the committee, and then you list a range of 30 to 60%. What does that mean? Does that mean that there will be a range, or that we're gonna pick
No.
one number in that range, but it hasn't been decided yet?
We
It's the
would,
second one.
we would pick another.
Right, so there's still some decision,
Yes,
so that's
There's
yellow.
still some.
Yellowish.
Yeah, and
Yeah.
that's, Richard will talk more about that.
Okay.
I just want to say my last part is, our target has been February for our final recommendations to the board. We don't think we're going to make that timeline. We're skeptical. So we think we probably need a couple more months in order to make the recommendations to the board. We may have another straw proposal, to get ready, but it's taking more time. And I mean, I would love to be all completely done by February, but I just don't know that that's realistic. And I think my committee members would all say that. So
So one other thing, I apologize, and I don't let you jump in, Richard, I see on this slide, and I hear kind of in the discussion that, that you're possibly looking for some more guidance from the board on some of these decisions. And while we won't be making a decision in January, I wonder if we can have a tax discussion in January. And then we can do what we were going to do today, which is sort of, you know, kind of line us up for that discussion and talk through some of these bigger issues.
Yeah.
And then the board could give some direction to the committee about,
That would be helpful.
about kind of where we think the taxes should land.
Uh-huh.
But I would rely on Richard or anybody else you determine, to kind of do sort of a lot of presenting at that meeting, like spend an hour at the
Yeah.
January meeting.
Yes.
Talking about like, here's the things that we're considering, and then the board can weigh in on direction. And then that might make your future committee decisions a little bit more streamlined. Would that work?
Yes, that'd
Okay.
be great.
Awesome.
Thank you.
Let's plan for that for January. Okay, great. I
So
apologize. Go ahead.
I would hand it over to you two to say more.
Cheryl, I think you've done a great job. I don't have a lot to add. I would say that this issue of how much credit to apply against the healthcare personal income tax from what the employer paid in the payroll tax has taken more committee time than any other single issue. And it's all about taxes, and it's about fairness, and it's about all the credits from 30%, 45%, and 60%, they're all progressive. So that's not the issue. The issue is, how do you dial that in? And there's pros and cons on that. And I think that fits well into a January discussion, because it's really all about taxes and fairness across the people that are mostly Medicare, the people that are all wages, the people that are self-employed, and the people that have a mix of income. The 60% EPT credit gets us where it's most even across those groups, and that argues strongly for that, for the 60%. But having a rate of health EPT, I mean, employer payroll tax credit of 60% also puts up the healthcare personal income tax rate above 10% to 10.6%. So there's pros and cons. If you have an EPT credit of 30%, then the healthcare personal income tax rate goes to 8.92%. So keeping it below 10%. But anyway, it's a good discussion to have, but it's taken more committee time than any other topic we've talked about.
Yeah, and because it really, sorry.
I'm sorry, I was gonna say, if we have maybe 5 more minutes, then we do have 3 slides, showing those proposals, if you feel like we have time, Chair.
Yes, yeah, let's do that. But yeah, I would say that because it involves values and because it involves principles, because it's about
Yes.
fairness and progressiveness and so, then I think it is worth sort of a full board sort of view on the kinds of things you're discussing so that the board can weigh in on that direct. Yeah, go ahead.
Right, oh, thank you. So yes, if you want to, so these, I put these at the end of the slide deck. So again, people can have them for reference. We're not expecting any decisions or anything to come from the board today, but again, wanting the board to know what the Finance and Revenue Committee is looking at. So just so people understand, the next 3 slides, these reference slides, are different scenarios, just as Cheryl was speaking about, of having a different employer payroll tax credit and the different percentages on all of these scenarios, though. Note that there is that built into it, the 100% Medicare Part B credit against the HCPIT, and that there is no soft cap built into these next 3 scenarios. So if you can go to the next slide, and I don't mind, Richard, would you mind describing, oops, go this one. There we go.
So this is Plan A, which 30% employer payroll tax credit and a 8.9% healthcare personal income tax rate. And the 2 graphs are the same graph of it, just the one on the left zooms to lower incomes from 0 to 200,000. The one on the right goes up to $1.4 million of income. The difference in the colors are the exemptions, which is essentially family size rate readjustment. And so the point, and along the left-hand axis, you have the personal income tax rate net of the employer payroll tax credit. And along the bottom, you have the income. And so the idea is that if it's sloping upward, it's progressive. So that's the point of having these 2 graphs, is that at all income levels, it's progressive.
And so this one is Plan A. So I think what's helpful is you have the employer payroll tax credit percentage with the personal income tax, just so people get this idea of the range. And then if you want to go to the next slide, Plan D, the 45% employer payroll tax credit. So then you'll notice the personal income tax rate goes up. And then the next slide, Plan E, Again, now you have a 60% employer payroll tax credit, but a 10.66 personal income tax rate. So again, not wanting to spend a lot of time, I just wanted people to know that these are available at the very end of the slide deck, which will be a revised slide deck will be posted. But again, and really there had been a lot of discussion about progressivity. And I know Chair Blanca read something someone wrote in about that, very concerned, understandably, that what was proposed was not progressive. And I think, as Cheryl alluded to, that the Finance and Revenue Committee has been very scrupulous and very careful to include progressivity in their recommendations. And this, I know not everyone likes looking at graphs, but for those of us who are visual learners, that slope, the fact that things are different at different income levels defines the progressivity of what's happening. So that's why we wanted to share those.
Just to clarify too, from my point of view, the tax itself is not progressive. The tax itself is a flat tax, but it becomes progressive because of the credit that we allow. So when you give certain amounts of credit, you build in progressivity.
No, the progressivity starts with the fact that the first 200% of federal poverty level income is not taxed.
Exactly.
And just doing that creates progressivity.
Right, and okay, but it's not a progressive tax per se because it is a flat tax.
Well, between two, sorry, I apologize for bringing this up, between 200 and 260%, it ramps up. So it's not nothing and then whatever percentage. So that's the other part of it too.
Okay.
But I agree. I like to think that the revenue plan, if people, is progressive, but even within that healthcare personal income tax, there is progressivity.
Okay, so these HCPIT tax rates that we're seeing on these slides, that doesn't apply to the whole population. It applies to the top of the population. And that the lower income levels wouldn't have 10.66 in this scenario, they would have a lower rate.
Yes, as you see there, there's no tax there. It's flat for everyone through around 2% of federal poverty level, which is going to be 31,000 for an individual and some 60,000 for a family.
Right, but that rate is the net HCPIT rate,
Right.
meaning it's
After the credit.
after the credit. So it's the credit that makes it progressive, not the tax itself.
And Morgan may be able to weigh in.
Oh, is Morgan? Thank you. Morgan, if Morgan is there.
And Charlie just chimed in the chat as well. I think the confusion here is when people see the rate, they figure like, oh, it's a rate charged against my income. But they also have to remember that the income, how the tax treats, how our tax structure treats your income is not what you think it is, right? So with exemptions, phase-ins, and then the credit on top of it are all the things that contribute to it. So I think what Richard said is correct, right? So remember, even though the rate applies, your income, what you think your income is effectively zero because so much of what is what we're calling income is exempted, and then phases in, and then the effect of the credit is even layered on top of that.
Okay. Yeah. Okay. Yeah, let's spend some time on this in January and just dig into it with scenarios so that we can see how it plays out too.
But to be clear, the reason it's progressive is not because of the EPT credit. It's not because of the EPT credit. It's progressive because the first 200% of federal poverty level income is not taxed. So that amortizes as income goes up, that gradually, when you get out to say $300,000, the first $60,000 of income is not exempt. So you're paying a higher rate of your total income than someone who's at $75,000.
Okay,
So
yes,
that creates
that
the-
helps, right.
That creates a problem, not the EPT credit.
Right, the impact of that first 200% is much more meaningful at the lower income levels and so forth. Got it, okay, thank you.
And I think one thing that the committee is still struggling with is whether to exempt that first 200% or not. Or we know that we have to exempt the first 138% because that's Medicaid rules. But in Oregon, because we've expanded, and like you said, that you felt strongly that it needed to be the 200. And I think the committee is leaning very much that way, but that is still under discussion. And the other thing that I think people need to understand about this employee tax credit, one of the reasons that it's difficult is thinking about people who are self-employed, who don't have an employer paying, that will really reduce the amount they have versus those who are employed. And 85% of the state people are employed by an employer, you know, and so, and then also the issue about where does Medicare fit in this? So it is a lot of moving parts that we are, I just guess I want on the record that this committee is taking all this input, thinking about it, and trying to take a tax system that we have and which isn't always, it's quoted progressive and it's better than a sales tax, but there are still some non-progressive things in the tax system. And so we're trying to kind of, and so when you do move this one up, it jiggers this one down.
Yeah.
So anyway, but
Yeah.
overall, I want people to understand part of the reason they struggle on how much of that EPT to credit is that it really was more like starting out thinking about let's do it all. But then what does that do to the self-employed people?
Okay. Okay, great. Thank you. That's really helpful. Okay. Okay. Anything else from finance? No? I think that'll be awesome.
Thank you very much.
Good job.
Okay, very briefly, I'll do a brief overview of plan design and expenditures. At our last meeting, we had an update from Milliman on our expenditure, projected expenditures, so I'll show you that in a moment. And then the work that we're sort of engaging in now is revising our behavioral health proposal and really thinking through long-term services and supports and how that might work. So those are not yet ready for proposals, but those will be coming soon. So very quickly, I just want to show you Milliman expenditure estimates. So we asked them to revise their expenditure from last time, and basically these are the kinds of things that they were reducing. We asked them to pull out long-term services and supports based on the agreement from the board to do that, and then non-resident workers were excluded. They didn't, that was just an oversight, so this board had already agreed to that. They reduced their projections for adverse selection, which is the term they use for in-migration of folks coming to Oregon because of the Universal Health Plan. They reduced the estimates for induced utilization, and then a couple of other assumption refinements around pharmaceutical expenditures. And so next slide is, this is 2030. I'm going to skip this because we weren't sure where the board would land in terms of timeline. So we can skip this slide and the next one because they refer to 2030 data. So this slide is just, we asked them to also make projections for 2032 in case that's where the board landed. And since we did, we'll just focus on this. So on the left bubbles, you can see they give a range of a low estimate and a high estimate for what the UHP would cost in 2030. And then they used medical trend and population shifts to sort of add costs to get us to 2032. And so that's how they came up with these 2032 recommendations. So next slide, the bottom line here is, it's my notes, I apologize. This slide shows, so the status quo is the top row. That's if we do nothing. That's without the UHP. So in 2032, our status quo healthcare expenditures are projected to be between 76 and 66. I'm sorry, I can't read it. I don't have, it's too blurry in my slide. It's like 68 to 76 billion dollars. And with so roughly averages out to about $71 billion if we do nothing. So status quo, middle of that range is about $71 billion if we do nothing. And then the range for a 2032 Universal Health Plan expenditures is somewhere between 73 and $87 billion. Middle of the road would be $81 billion. So so roughly $81 billion is our target amount that we're thinking for expenditures for UHP at this point after these most recent adjustments. It's a lot of money. And it is more than if we did nothing. So it's roughly 71 billion if we did nothing. It's roughly 81 billion if we did the UHP. And that accounts for enhanced benefit design and covering more people. So these numbers do account for these HR1 adjustments, with a lot of people losing their insurance here in the next few years. And so we have to bring all of them on board. So, so that's that $10 billion difference. Again, these are just expenditures that are strictly related to the delivery of medical care. These do not include administrative costs or administrative savings that we would accrue. These are just the spending money to take care of people. So that would need to be pulled in later. And then last slide. We are talking about cost containment and looking at various buckets of cost containment and how we could approach that. including how we reimburse providers. Medical management refers to utilization controls and how we could get the best deals possible for pharmaceuticals. Thinking about if we were going to reduce benefits in order to reduce costs, what would that look like? And of course, those ideas would come to the board. And then any kind of cost sharing, if we would be willing to entertain certain elements of cost sharing with the population in order to reduce costs. And then eligibility in terms of residency and graduated benefits. So all of those are proposals by Milliman to cut costs. The committee has not made any decisions on these yet. That's just what they're going to be bringing to us in terms of information. That's all I have. I'm going to turn it over to, oh, sorry, if any questions on that, otherwise I'll move on to operations. Yeah, go ahead.
I guess just maybe more a comment that, on the draft expenditures that don't yet include, the savings from our current administrative burden and the for-profit nature of our current system.
Yes.
So I think before we can broadly share that, that will be very important. Because right now, of course,
Yeah, we need to incorporate those dollars to look at the whole plan.
Okay.
Absolutely.
So that's coming like in the next month or so, or.
Not sure what they estimated they'd get that number to us.
Okay, I'm just saying because this is a public meeting, people are seeing this.
Right, that's why I
This-
emphasize it's just medical expenditures. It's not the whole cost of the plan. It's just what we would spend to deliver medical care.
And then on the cost sharing concept, looking at the cost of the administrative burden for days or whatever the cost sharing mechanism is gonna be very considered.
It's very expensive to let co-pays.
Yes.
Yes,
Okay.
yes, and we know about that and we're considering that as well, yeah. Mary Lou, did you have a comment or? Your name check, so.
Oh, I'm sorry, I don't think about that.
Okay. Okay. Anyone else?
And I can do this reiterating these things for people who don't go to your committee meeting.
Yes.
Because this is being presented publicly and without the context. And people begin this conversation, they just,
Yeah, absolutely. Thank you, yeah.
And I guess that was one of the things when I was observing the meeting, that Milliman didn't really have numbers on that administrative stuff. Fritz kind of gave his own personal opinion, but really didn't have, that, and we've struggled with that with HMA, with a variety of places, and our finance committee, we discussed that a lot, and ended up with the 8%, but
It's a hard thing to estimate.
it is.
and it's also one of the key selling points.
Exactly.
Right, and so we need to figure out what is it to get.
They're working on it and they know that that's part of their deliverable for the plan, but it's a tricky number to come up with. This is a way easier number because we have claims data. So that's what they came up with first, yeah. Okay, great. I'm going to turn it over to Judy for operations.
Thanks, Chair. So I'd like to give a report on the work of the Operations Committee. We've had 2 meetings since our previous board meeting, so there's a bit to discuss. After listening to my fellow board members and wanting to save some time for public comment, I would like to table the vote or the approval on the partial enrollment discussion pending staff. Maybe will that cause any unintended consequences? Okay, great. And I'll explain why as we go through it. Next slide. Okay, so the first part gets to the question, what is the administrative cost? Well, to get to the administrative cost, you need to know what does the corporation or the trust look like. This was provided by Milliman. It's a general structure for a health plan. So if you're looking through the packet, this first slide is in general, what are the buckets, roles, departments, if you will, of a health plan, and what are the jobs that they do? Next slide, please. If we adopt that to a universal health plan, there are some features that don't exist in health plans now that maybe we've seen some previews of in CCOs, maybe perhaps intention to reach out. Those are in the purple sections, and I would like to draw the board's attention to that long purple column. That is a chief strategy officer, and look at those functions under there. It's microscopic. So I know my bifocals don't show up. Please take a little bit of time, if you haven't already noodled on this slide, to look at it. after the board meeting, and send questions over to staff and they can, ping me. I'd be more than happy to sit through with you and go through, Milliman's hard work at pulling this together and why they think some of those, elements belong in the purple section. So with this to, Amy and Mary Lou's question, with this, we can build out with some knowledge of how many regions are there, what do those look like, what is the administrative and operational cost of this? And then I think it's to the harder question is what's the gap, right? Is there a savings? And if so, what is that? Because this is expensive to run, right? Just like Alpha. Next slide. All right, so I'll briefly preview what I'd like you to consider for the next board meeting. Go ahead. We talked a little bit about, well, how do people enroll in this plan? How do we know when coverage starts? What are all of the different options? And my deep gratitude to staff that dug around and found lots of options for the committee to consider. And we've consolidated around a little bit when it involves re-enrollment. So when do we ask for Oregonians to tell us again, they're still in Oregon and need care? So we've had those discussions. Once again, please take a little bit of time with these slides. I'd like to come back with the whole tamale, if you will, which includes the re-enrollment process, enrollment verification, including like what sort of document or, mail, or how do we ensure someone is in Oregon to receive care? And then also enrollment for new members as we start off. How do we know who's in the state, who's going to need care? Go ahead, next slide. Okay, so this is the detail that I'd like you to really consider, and please send questions to staff. Once again, I'd be more than happy to sit down and discuss prior to the next board meeting, and then we can also. So you have 15. Oh, okay. Then we can also discuss this at next board meeting too, within the context of initial enrollment, re-enrollment, and then establishing a status, residence status within this state. Great discussion in the committee about this and really some deep thought, thinking about all populations, whether or not you're housed, not carceral, etc. Go ahead. Any questions about this so far? Like how Marilyn.
Can you go back to that slide?
Sure.
So because we know that a lot of low income people don't file income tax. So you think they will be picked up in the secondary mechanism that they have SNAP benefits or they have something else that has made them whatever, but I just do know that there's a lot of people who just don't have enough income.
Exactly.
That they don't file a tax return.
Absolute method.
Okay.
Yeah.
So the second bucket of people is kind of in that presumptive eligibility. Concept.
Yeah, so says here 75 to 85% of people are captured just by taxes.
Right.
And then the majority of the non-filers would be captured by their participation in those other programs.
Yeah, exactly. Am I missing anything on that, Lee? Yeah. Okay. Let's go ahead and skip. Enrollment verification, we discussed quite a lot about, well, what sort of identification do you want someone to present so that we can put them on the rolls? So these are the different buckets. Prioritizing an ease of enrollment, knowing what we know about how folks, how churn happens if folks drop off rolls if require frequent re-enrollment. So please take a look at these because they'll be relevant as we come back to vote next month. Any questions initially?
I have a question.
Yeah.
We talked a little bit too about like people could just show up for healthcare somewhere and get enrolled at the point of care. Is that part of the?
Yeah, we've actually tabled subrogation. So if they're covered by another state plan or they have other insurance and they show up in Oregon and get care, we can go find ways to get funding, but we still haven't discussed at what point are they enrolled. I think we want to decouple it giving care with getting paid for care in that case. So they show up as like in EMTALA, you treat that their emergency care. Should then either at the same time figure out enrollment, or there's several like durations of waiting period that we propose, or there's like you provide care, automatically get enrolled, showing up with verification happen at the same time, like you ask someone for their their Oregon driver's license or their mail or what have you for identification. Then you provide care, or you if they have specialty care or they need referral, then they have this waiting period that enacts, but we haven't figured out yet in the committee what we want to recommend to the board. We're still considering all those buckets, which I think is good to take our time and noodle on it, because you really want to try and see it from all of the different facets and perspectives. Did I answer your question? Yes, okay. Go ahead. The next topic is one that I want to spend a little bit of time on, because I want to explain how we came about with regions. Now, we don't have a straw proposal for this because we were really taking direction from the board initially that there will be regional entities. And so when we went back to the committee, thankfully had great staff support and input, asking how would you divide up the state? Now, I want to start this discussion by saying you can get care anywhere in the state of Oregon. Like if you live in Eastern Oregon and you want care on the coast, you can. There's no confined networks. It's not like the CCOs where you can only get care in your CCO and they'd have to figure out care, go outside of that. If you're out of network or you stuck with having to pay for care. There's not any of that. So really the things to consider are how far you have to drive, you know, thinking about where you may get care, and then going back for giving your opinion about what maybe services or other community engagement offerings are in that area, and really kind of regional identity. So to be honest, in Oregon, we have distinct regions where folks feel like they may say, I'm an Oregonian, but they may also say, I'm an Eastern Oregonian first. And the folks who live by me know what it's like to work in a ranch, and they know what it's like to homeschool my kids and have to, whatever, all those other things that are add to social determinants of health, but also add to kind of how they view their healthcare, and get help for care when it doesn't work well or work right. Which is why I think, you know, I've heard two things on the board, that we're looking at a central database that will cover the state. Yes, but I've also heard the importance of moving around to engage people around the state. You know, anybody in the state, anybody in the country could zoom in and listen to our meetings, right? But if we go to the different areas, there's this sense that local people know who I am and they understand what my needs are. And if something happens, if something is not covered under my plan, but I need to go talk to a person, I don't want to be in a call center talking to somebody, heaven forbid, I live where I am and I have to call somebody in Portland, you know, that's bad. There needs to be their plan, and they need to feel like this is their resource and they have somebody that they can connect with. So we thought about how far is it to drive to go see somebody in person? And we looked at several ways to divide up the map. We thought,
So on this slide, the second bullet says primary care and behavioral care networks, but that is not a network in terms of you're limited to seeing somebody in that area.
Thank you for the clarification. You're correct. It is not. Those are like medical homes. So you can pick where your medical home network is. They're very tightly connected and care is provided hopefully more seamlessly than like if you got behavioral health in Pendleton and physical health in Portland. It may be harder, maybe not, but it may be harder to connect those two and provided that medical home. So that we should change network.
Yes, well, that word.
Yeah.
So that, in that context, it's how primary care and behavioral health work
Work
together
yes.
with each other. It has nothing to do with limiting where people get care.
100%.
People can get care wherever they want.
Yes.
Okay.
Like some kind of bad words. Yeah, no, not like that. You can get care anywhere. There's gonna be regional areas where it's more coordinated and you have like your node.
Yeah, great.
Yeah. So, yeah, great. We thought you could divide the map up a number of ways. You could apply a grid to it and just say, you know, like the grid map. There are ways that Oregon has been sectioned that have been helpful identifying regions. One of those is the way public health is distributed, kind of related to counties, but not entirely. The other consideration we had when we were talking about dividing up the map is, you know, you want to be able to somewhat level set resources so that, you know, one area doesn't feel super crammed and crowded and you have to really build a huge amount of resources to support all those folks. And then maybe you have one person who's like way out in Eastern Oregon, Ontario, and they, you know, they're stretched. So you want to be able to somewhat, you're not gonna be able to match entirely, but somewhat level set that. So we thought the public health division map would be the best one. We thought about trauma anchors, or, you know, when we have the trauma system, just because of the way the roads work and the way people travel. And then there was another kind of hybrid macro model. The community liked option A. Do we have it? Picture? Yes. So this is kind of the way public health districts are divided up. It's called socially geographically drawn, what I call a regional identity. So I think that helps folks. It kind of builds on connections. I won't use networks, connections we already have. So in my mind, thinking too as a clinician, referral patterns and folks that I currently work with, if someone is in my office and they're a mental health crisis, I know who I'm calling because they are nearby me and I've used them for ages. And so I think that helps, you know, when we're building that familiarity. Rural regions cover large areas. Yeah, we always have.
Can I just ask roughly population wise?
Yeah.
How do these, are they roughly?
That's the next slide.
Okay.
So those colors match these regional areas. Wait, how do we read it?
Yeah, I was gonna say, I'm happy to offer some.
Go ahead.
And just here, so. Metro is the biggest at the very bottom there, A7 at 190,000. And then North Coast, which is the second one, is 233,000. Yeah, and other ones are, you know, 320, 388, 582, and 726.
So I know it's really hard to change our thinking away from networks. So I was gonna offer a better way to think. I'm up for anyone who would like to describe this differently. I think if there were an element of innovation, so if there was some regional innovation funding, this region could decide for themselves, how would we like to innovate the model? How do we like to speak our voice to maybe the central UHP board? How do we feel represented in this statewide system? And so dividing it this way felt familiar, like, you know, Oregon neighborhoods.
And no counties are split.
Yes,
No.
correct.
Yeah, so that's nice.
It is. Yeah, so go ahead.
One thing I would just add to, these are, as Judy mentioned, based around what I call the social geography, but they are also designed to, within that, then match as closely as possible those trauma regions as well. So you do see in that last column kind of how it fits with the trauma regions, and it's not perfect because we are looking more at kind of socially which counties tend to work together, but there's definitely a nod to trying to acknowledge referral patterns.
Yeah, and how far people go for care. I mean, if you have a preemie who has to go into the NICU, you want to go to the place that you've gone to before, you know, that's, you know, that you've already established with, and if they're within your region, you can give feedback, you can grow your own innovation there. So, did we finish this? Yeah.
And can I just ask another two? Regarding the trauma regions, that piece is important because of emergency preparedness, right? So that's like on a state level, what we need to be thinking about is when there are natural disasters or crises or trauma, the way that federal money would come to Oregon for support and the way state money would be distributed, and the way communications happen in the state is based on those trauma regions. So aligning with those is really critical for emergency preparedness reasons and natural disasters. Is that, yeah.
But I think clearly saying what I heard and what I heard Judy saying is that nothing precludes anybody
Not a bit.
for going wherever they would like to go. And so they've heard there's a great thing in Seaside, so they're gonna go there versus that they live in the Dalles. And so there's nothing about this. And then I guess back to Lou Siniger continuing to give his input over, you know, the bricks and mortar, the cost, those kinds of things. That really hasn't been decided that there's gonna be a building in these places for what does that really mean in terms of the administrative?
Well,
staff?
we're getting closer towards the administrative costs and we haven't, I don't think we've developed committee consensus or had that discussion about a bricks and mortar. I certainly have my preferences, but that would be, I think that's important to get the sense for the community of Oregon and what's meaningful for them. I'm sure there will be
Yeah.
some.
Anyway, I just.
Yeah.
Anything else? Any other discussion?
We'll be voting next month on.
I would like to vote on this, it's this month that we are seeking board approval for regional designation. That would help us because we've been sitting on this for
Yes.
2 months, 3 months.
Okay, so you.
Thank you.
Wanna make a motion?
I would entertain a motion or.
Okay.
So move.
So the motion is to approve selection of option A for the regional designations, which is the public health-based option as a framework for determining regional boundaries for universal health plan. And it's been moved and seconded. Any discussion? Great, so roll call vote?
Ellen Belanca,
Yes.
Chen Wei Chi is absent, Amy Fellows,
Yes.
Michelle Glass has exited the meeting, Bruce Goldberg is on leave, Judy Richardson.
Yes.
Cheryl Ramirez.
Yes.
Mary Lou Henrich.
Yes.
Mike Leahy.
Yes.
That's everyone. Thank you.
So clearly that vote passed, but just as a point of clarification, regardless of how many board members are here, we still need 5 members to pass any motion for it to, it's not a majority of who's here, it's a majority of the board, so. Yeah, so that's great.
That's it. Thank you, Chair.
Awesome. Excellent. Whew. Nice work, everyone. Okay. So at this point, so we have moved, so on the agenda, it's listed as meeting takeaways and future meeting topics. As Mimi said, because all presentations now go through her, that the part about board outreach now goes directly to Mimi, and that'll be part of her report. But at this point in the meeting, I want to open it up to board members to suggest future meeting topics. I already made one. I want to spend the bulk of the next meeting really thinking about taxes and what the board's priorities and values are around how to think about taxes and guide the Finance and Revenue Committee on those decisions. So that's for sure. Does anyone have other topics that they want to make sure we cover in future meetings? Yeah.
Well, it may be a nuance of what you stated. So, I listened to all the stuff and it's wonderful work. But when you get to some pieces, I'll take as an example, when, sort of Richard on this. If I were gonna be presenting something to people and I told them, we're considering something that would increase the marginal tax rate by 10% or so. I mean, we gotta be kidding ourselves. We think that's gonna fly. I mean, unless I'm wrong, I think that's,
Right, so I mean, you're talking about how much it would cost for people to participate.
well, today, when we had 30, 60, and 45. Once people begin to understand what those numbers are, I don't want us have the same result as we had a number of years ago, where we put something like this to a vote and 75% of the people rejected it. So I'm
Right.
really saying, at some point, I want to make sure that when we have technical conversations, that we continue to have some level of common sense.
Right, exactly. So that's what we're hoping to dig into next meeting.
Great.
Yeah. Any other topics for discussion?
Mine's less of a topic, but something I forgot to ask. But it might be a future topic or just a reflection. Wondering what the current timeline is on the finance and revenue and then design groups to, like, it sounds like there's still a lot of independent work being needed between those two committees, but there was a plan for them to come together at some point and just
Right.
wondering where that's at.
It doesn't seem like it's feasible for those two committees to get together and hash things out, but that reconciliation is part of the reconciliation that I was mentioning that the board is going to need to do between expenditures and revenue. So yes, consultants, staff, maybe representatives from the committee, definitely all of this board members, will all be involved in doing that reconciliation. We'll see what we can come up with revenue. We'll see what their expenditures are. It's gonna be a massive board discussion and decision around how we want to balance those two. I don't think it's up to the committees. I think it's up to the board to
Okay,
figure
I
out
just
that
had
reconciliation.
a
Yeah.
that changed.
Yeah.
So, thank you.
Anything else?
Oh, yep, you're gonna be called upon in a second.
Okay, great. Then let's move to public comment and I'll turn it over to Isabel. Isabel, how many people do we have for public comment?
We have 5 today.
And, I'm gonna I asked Mike Huntington, this is more of an announcement, but because he has the details, I asked him to give it. Which we just heard about in the middle, so I'm just gonna have Mike go right now.
Oh,
It'll just need a second, and then we'll get the other ones, because I appreciate this.
A little bit of uplifting news. 2 weeks ago, this is the first time ever that Senator Wyden has shown interest in universal health care. He allowed 6 of his staff members to meet with some of ours, I think Colin was there. Spent an hour to talk about the state-based Universal Health Care Act that was introduced by Senator Markey and Representative Filcana. And I think the reason he's interested is that it does not make him say he favors Medicare for all. This bill allows states to experiment. They could try public option, they could try Medicaid for all, and we're pretty sure that would fail. But at least it's not prescribing. So, a little uplifting.
Thought we need to go.
Okay.
Thanks, Mike.
okay.
We
So
just heard that
are there
meeting.
additional people or 5?
Now there's 4.
Now there's 4. Okay, so we have about 5 minutes left in the meeting. So we could either stay an extra 5 minutes and give everyone 3 minutes. Is that okay with everyone? Okay, we'll stay. That's fine. So go ahead, Isabel, I'll let you call and everyone will have 2 minutes.
Vern Savo, you're up first.
Yes, I'll make my comments, of course, brief. And it's relative to, I would admit, my overarching comments, I would characterize as sauce for the goose, meaning the work that you folks are doing. I have to tell you, we've just had some meetings. There's going to be an informational hearing in January regarding transparency and healthcare insurance. Senator Patterson is putting on. But I have to tell you, Oregonians, consumers, our patients and providers have tired of the endless games the commercial health insurers are playing. And most recently, double copays, double deductibles that the consumer is not aware of, arbitrary denials. We had a situation with one carrier where they changed the modifiers for procedural codes. I'm not going to explain all that, but modifiers that we've used for years, changed them without any notification. And when we asked what the new modifier is, they said they could not give us that information and referred us to the 1100-page provider manual to find those. When we reviewed those, it was a nothing burger. They weren't in there. That type of situation. And then in one particular case, when the patient or provider wants some clarification or help, we call a call center, which happens to be in the Philippines. So these are going to, this stuff's going to be talked about in Senator Patterson's informational hearing in January. And we suspect it may or may not be secondary to the subsidies from the American Care, the ACA, Accountable Care Act, excuse me, the subsidies which were extended in 2021 via the Inflation Reduction Act, those are coming to an end. But nonetheless, I really hope that your work comes to completion and we don't have to deal with those games. Thank you.
Thank you so much.
Thank you, and apologies, I was incorrect before. There are 5. And next is Colin.
Hi, hello.
Hi.
I'm Colin Stackhouse. I work with Healthcare for All Oregon. I'm disappointed, and there's 3 things I'm disappointed about. One is in myself. I think if I'd been maybe more awake at 9:15, I could have articulated something that maybe would have changed one of your votes that you just did. A little context, the last meeting, feeling like public engagement is like, this is not good enough, right? So I sent an email to Mimi, Judy, Helen, Amy, and Michelle, basically, in short, saying that Healthcare for All Oregon would bend over backwards to do free public engagement sessions. And the response from Helen, somebody had to respond, and Helen basically said, no, that the ramped up public engagement is more important. In short, my interpretation is that the ramped up public engagement is necessary after September, and nobody in Healthcare for All Oregon agrees, right? So we helped in part create the bill to make this board, and none of us think that the public engagement draft process is up to snuff, right? So maybe if I'd articulated that before your vote about trying to get different meeting times, maybe you would have voted differently. But just to remind you, you just had the opportunity to see if there's in the next 6 months the opportunity to have a meeting somewhere else outside of Salem. And you just have the opportunity to schedule 3 meetings that are not 9 a.m. on a Thursday morning, and none of you did it, right? So you had the opportunity to try to increase the options for public engagement, and you chose not to. So it feels frustrating to be heard, but no action. Said that we're listened to, and again, no action to improve the public engagement. So, okay, thanks.
Thanks, Colin. Just to clarify, the request for public engagement, I did not say no to that. I just said timing is important, and I prefer that they happen. I think it's the wise thing to do to have them happen after September. So that wasn't a no, it was just a timing is important. Go ahead, next.
Next is Karen.
Hi, I'm Karen Baker. I've been an activist with HCAO for over 15 years and a supporter of universal healthcare for decades before that. When people are saying our healthcare is falling off a cliff, I'm a prime example in that I've been retired. My husband and I were lucky enough to retire early in our mid-50s. We budgeted at the time 10% of our income to go to healthcare. We were lucky. We had that enhanced subsidy. We were paying $149 last year. Next year, we're paying over $1,900 for our premiums. And that's a bronze plan with a $19,000 deductible. So, like I said, we're in a crisis. We're falling off a cliff. And I think when I heard 2032 as to implement, I was never naive enough to think this was going to happen before I turned Medicare. But I think we're at a crisis point where a lot of people are not going to have coverage next year because of these subsidies going away. So that's just, and I would like to say, when I budgeted 10% of my income, I thought that was reasonable. Next year, I'm paying 33% of my income to health insurance. And that doesn't even cover the cost of coverage that I need. Thank you.
Wow. Thank you. Next is Tom.
Tom Sinzik with Nurses and Friends for Single Payer. Boy, that was an exciting meeting, lots of data, really appreciated the data and the testing. But I think that some of the difficulties were really overstated. For one thing, HCO has been working on this already for the 25 years. We've taken care of the first 25 years. That's why the task force was formed. That's why the constitutional amendment got passed. That's why this group exists, because of that 25 years of work. And it was done in coalition. So the building is already there. Obviously, we want to continue to hear from the members of the coalition in fine tuning this, but that work is established. That is why this work is existing. In addition, with this thing, you should invite Richard Kimball either to this meeting, Dr. Kimball, or to a board meeting directly, not just a couple people hearing from him, but to one of the committees or this meeting. Regarding the regional entities, you should look at the overlay of the regional health equity coalitions to see how that fits into the public health. Maybe there's a little bit of adjustments, but there's already community boards that you can hear from, no brick and mortar needed. So let's see, assuming that small businesses and low income people don't want to pay anything at all is a false assumption. People, to reduce and get rid of the stress of this current system and the worry that's associated with, would clearly pay something. For myself, following up with Karen, tax me at 15%. Go ahead, add it to my current tax rate, 15%. And I won't have to worry about it. And I think I'd come out about even for the course. I'm a little luckier. I'm already in the retirement age. So I think, and then the last thing, I've heard that Governor Kitzhoffer has a meeting going on with a group of people. Can we hear about that meeting? And is there anybody here that's already been invited to participate? I'd like to know that, because as part of transparency, if there's a side conversation going on about the direction of this with the governor, we should know about it here. So I think that's it.
Point of clarification, I think you said Richard, I think you mean Stephen.
Stephen Kimball, sorry, Stephen Campbell.
Yeah, yeah.
Campbell, sorry about that.
That's okay, no, just.
Yeah, no, I think I got everything, and thank you for the time. Appreciate it.
Finally, we have Richard. Richard, did you sign up?
Oh, no,
Okay, then we're,
I'm sorry, I'm just doing the regular
okay,
attending.
great, then we're all good.
Great, we're all set. Okay, awesome. Then great, we just have a reflection, I believe, from Pete.
Oh, yes.
Right, me too.
Nope. Hold on. It's not up there, so let me. Thank you. I know it is. Yes, so my reflection, quote by Albert Einstein, you can never solve a problem on the level on which it was created. I mean, I think that there were early reasons that this country didn't do a universal health plan, and, you know, again, in potential Medicare and Medicaid, and a lot of them, quite frankly, have to do with racism and ableism, at a systemic level, and so those are still issues that will continue and that we need to be cognizant of as we move forward, and that is unspoken thing often in the I don't want to vote for someone else. Sorry, downer.
Would anyone like to volunteer to do the reflection?
But we can't do our work without being cognizant of it, so that's why I said.
Yeah, thank you, yes. We have a volunteer for reflection.
I don't think I've done it, so.
Okay.
I feel.
You're up. Thank you. Great. Thank you, everyone, for your attendance and participation, and we are adjourned. Thank you.